she tried the other one. She's supposed to be backstage, yeah. What's her? Let me see. Okay, let me send this link. Don't worry. Let me just send you a link. Don't worry. No, no, call her. Let me just send you a link.
Okay. Let's send her. Okay, directly. So Mr. Peter, I'm forwarding it to you.
Okay, fine. Yeah. So you need more volume for the volume on our podium. Then okay.
Okay, then.
Life happens, my guy. I don't know idea.
It's not really. I'm surprised.
That's
somebody else.
Leave this one first. Go to the slide.
Yeah, she's going for the slides.
She's the one presenting.
Yeah, she's one. She has a slide already. She said,
let me add that slide on here. So.
I'll come back now. Okay, fine.
Then you can call her and tell her to use this new thing.
You sent on that one, bro? No. Fine. You sent on that one, okay? You sent on that slide again just now. You deleted it.
Yes, I just sent you.
But sent it via the same Google Doc.
No, this is not my. This
yeah,
is not
like now.
You could have gone to my own chat so that you will not be confused. I'm Lisa. Yes, that's me. Yes.
Okay, just download it.
Yes.
Okay.
You can't hear anything in the whole day, man.
No, not just. I need to play this like.
Oh, display.
Hello, So.
Okay, she's here. Okay, no, she's not
here.
No,
they just send you another link. So use that one. You check your WhatsApp and use WhatsApp. What hall is this one?
He's controlling everywhere. These are all the halls.
No.
This one.
You guys all see up.
No, that's Anya, and then C version.
That's all C. That's the main one.
Okay, that's version.
Mr. Peter, just check if it's showing online. If it's showing on its screen. Are you displaying it already?
No, I'm not displaying it yet.
Just confirm.
It's not showing on the screen.
No, it's just those. See what's showing all those.
Okay, you're from our hall as well.
This is it, right? That is right.
Yes. So
first, go down. Let me see. Go to the next slide. Go. Yes, it's correct. It's correct. Yes.
So it's up now.
Okay.
Okay, now bring it up.
Okay, so she wants
if you full screen
covers like yes, it's on. Then volume, please.
Hello?
So make it a bit louder.
Yeah.
A bit louder.
Can you see our
Yeah, the look ahead.
Because she has read the message, so
can you send me a message? I beg. Can you send me a message? I did very tight down. I did confirm. I did very tight down here. Yes, not very much.
One man don't take any 1%.
Hold on.
But I think this is
There's a speaker that's on. There's a speaker that's on. There's a speaker that's on. Speaker, be mic. There's a mic that's on.
I don't know about Florida. I don't know what is happening. I've sent that to him. Let me tell him.
Let her just write her name, open the link, write her name, and then join it. This slide, is this the one you just gave me? I don't think it's the one you just gave me. Let me move it. You guys are no mosaic, bar?
Everyone.
of collaboration.
Project started in 2021 and it was started. Panel is Angela Aguirre, who's
Fine, please, I'm in a
protecting
conference. I'll call you
linkages
back.
for key and priority populations at at USAID. She's also the activity manager of the Mosaic project. She's a highly experienced project management specialist with over 10 years experience in project management, policy, and strategic level decision making. She currently serves as the project management specialist, testing and linkages for key and priority populations at USAID. She has a proven track record of developing effective strategies in public health and creating successful collaborations with government, public, and private sectors. She's committed to providing innovative solutions to challenging healthcare problems. Please make welcome Angela. Next in our panel is Shmuel HIV Vaccine and Microbicide Advocacy Society, now. She's a professional nurse, a public health practitioner, and the director of NAVMA, a renowned advocate. I believe a lot of us in the HIV space know her work, engagement in HIV prevention research. She provides national leadership in coalition for the acceleration of prevention research, CASPER, an international coalition that is working to support HIV prevention research and access to effective HIV prevention tools. She has vast experience in working with adolescent girls and young women. She's online, please make her welcome. Next on the panel is Dr. Joseph Ashiba. Ashiba works for Society of Family Health, Director on Global Fund and Project. He has 15 years experience implementing HIV, TB prevention care and treatment program among the general and key population. He has vast experience in health system strengthening, including prevention of perinatal transmission, monitoring and evaluation of other HIV prevention. Objective panel and provide just a brief overview of the progress that has been made across the product production framework for CAP, and then we'll launch into the panel discussion. So we'll save some time at the end for Q&A, and then the wrap. Next slide. I have my slides. Okay, so while the slides are coming up, I'll just provide the reason behind this. We're trying to bring together these key stakeholders to share early insights and learnings from all the efforts that have gone into expanding HIV prevention
I don't know. Yeah, they didn't manage the system well. Happy me no highest. I'm gone before. When the
all the things that need to be done for the product to be introduced. And then that report was disseminated to the PrEP subcommittee, and key decisions were made in June 2023, which led to the development of the CAP PrEP plan and a roadmap for Nigeria. And then the PrEP subcommittee also determined that a pilot would be necessary to understand key learnings from the initial introduction of this new product. And in September 2023, Nigeria did receive regulatory approval for CAP PrEP from NAFDAC in Nigeria. And then the research concept for the pilot was finalized by NASCAP also in October 2023. Right now, where we are in Nigeria is that CAP PrEP has been integrated into the national guidelines. And so in the newest version of the national guidelines that was just drafted in January 2024 and currently being finalized by the NASCAP team, CAP PrEP has been included as an option for HIV prevention. Also, NASCAP is in the process of developing resource packages for training providers on how to effectively provide this new product. They're also developing a 4-year plan for how we're going to roll out PrEP, and not just CAP PrEP, oral PrEP, how we're going to scale up, continue to scale up oral PrEP whilst introducing CAP PrEP into the prevention landscape. Right, so now that we know where we are in the process, it's still very nascent. We'll launch into the panel discussion, and I'll start to ask panelist questions so that we can learn a little more.
Then now you can put Florida on.
Florida is up already. She's not just on. Look at her.
We are video. We should show.
Camera is not on. My mic is not on. Just on.
So she's not what they'll be seeing.
Start off the discussion. I'll ask Mr. Simon a question related to stakeholder coordination and creating an enabling policy environment. As the topic of discussion states, we're harnessing the power of collaboration. And it's not always an easy job trying to bring together partners, donors, and all the various pieces of the puzzle that come together to make this beautiful pot of soup that we're trying to cook. So I'll ask Mr. Taiwo, as he leads the prep desk, what stakeholder coordination mechanisms has NASCAP employed to support CAP prep introduction in Nigeria?
Okay. Thank you, Dr. Eileen. That's so the mechanism that we have adopted at national, one of the mechanisms is stakeholders engagement. So we are engaged a lot of stakeholders for this, a lot of stakeholders. We have our implemental partner, our donor partner, our implementing partner, all of them. And there's something we call partner coordination meeting that we do. So this partner, we call them together to ensure that all of us are on the same boat. All of us are on the same page to carry out all this activity. So at the beginning of every year, we line up our activity, work plan, we call the partners together to align with government what we are doing, so that when they are planning their activities or plan of the year, we make sure that it aligns with government of Nigeria plan. Also, and introduction of CAPREP to Nigeria, we have a lot of stakeholders meeting that we had, a lot of stakeholders meeting. We have core group and we have general stakeholders. So some of our core group include NACA, USAID, the PEPFAR family anyway, all the agencies in PEPFAR, they are there, the WHO, CHI, AHA, these are the core people that we meet regularly. We meet virtually, we meet physically, and to ensure that the introduction of CAPREP into the country, come easily. And apart from that, all the deliberation that was announced, we table it to the general stakeholders. During our press, all these updates is given to the general house for them to be aware what has been agreed. So apart from that, that one, we have there was a time that we all have a high-level stakeholders meeting. We met with our boss and we call all these partners together, especially in the introduction of this CAPREP. So how are we going to carry out this CAPREP? And it's new into the country. So, and we agreed that we should have a small scale feasibility study to know how this CAPREP is going to be carried out in Nigeria. So a protocol has been developed already for that, though and about to be finalized. A protocol has been developed for that, and then very soon the stakeholders will be engaged also to finalize the stakeholders. For now, that is what we are doing for now.
Thank you so much for that response. And yes, it has really been a long journey to where we are. And like Mr. Taiwo was describing, it has taken a lot of engagement at all the track at most 150 days. So if you have all your documentation, and this
Focus your camera.
maximum timeline is dependent on the fact that you're able to provide all the required documentation or registration. But fingers. Registration that with treatment, but for so that we are ready to get the NREC approval, because now the implementation is going to be Nigeria-wide, not just for a particular state. So there has to be a well-developed protocol that gets NREC approval for its implementation, and also for NAFDAC to also review the protocol and with guidance and give their own approval. These processes run concurrently: NREC protocol approval and the NAFDAC approval for the protocol. So all these things are things we need to really sit down while we're thinking towards the implementation. We need to begin to think seriously, because I don't know when the scale out or implementation will actually be, but it is a critical component, because we don't want a situation where we introduce a product and we begin to think, oh my God, it is causing a lot of safety concerns, and we now begin to think of withdrawing it from the system. Adequate planning and budgeting is very, very instrumental in everything. If you don't plan well, you plan to fail. So I think that this is a very key area from the regulatory point of view that we should be thinking about. I know NASDAQ works with NASDAQ in the introduction of a lot of new products. Yeah, that I think their TSM, the prevention. I don't know who is handling it within NASDAQ now, because I don't know what their internal structures are. But I think it is time to begin to come to talk with the pharmacovigilance directorate, because after registration, a key component is how do we monitor the safety, and it has to be an integral part of whatever implementation. Angela Agway from USAID, and she'll be talking a little bit about CAB, the CAB pilot implementation and some of the facility readiness activities, readiness activities needed in terms of capacity building for providers. And I'll start by asking her, so that maybe we'll answer some of the questions already posed by Dr. Lemuwa. If Madam Angela, can you please provide us an overview of the plans for the CAB pilot implementation? Thank you, Helen. Thank you also for inviting me to be on this panel. It's really a privilege here. So I think the truth is that CAB is new in Nigeria, and it's also new in the world, across the world. So there were a lot of things that need to be put in place for us to implement and roll out CAB in Nigeria. So for USAID, and not just USAID, it's the entire PEPFAR team, which comprises, which is the HIV, US government HIV program in Nigeria. We did have to, first of all, develop a concept, because, as you're aware, CAB is availability of CAB across the entire world is little, so very few countries are being prioritized, even for CAB, to receive CAB. So Nigeria, we had to do a lot of justification, write a very strong concept, and did a lot of advocacy, even with HQ team, to be able to ensure that Nigeria is prioritized. Mosaic, as Helen had mentioned, that PEPFAR funds through USAID, and most of their work will support introduction of new biomedical products. So we had to pull that mechanism strongly to be able to support
um, that whole process in country, even with the government, Ministry of Health, and also, of course, working with all other stakeholders and the PEPFAR technical working group as well to ensure that we are all collaboratively, as Mr. Taiwo had said, working to ensure that we have all things in place as a country to be able to receive these new products. So as part of that process, also preparedness, um, USAID also was able to pull a few technical persons, including someone from the Ministry of Health, to a training, regional training for countries that were going to roll out CAP, and that was held in Zambia. And so we had about 4 participants from Nigeria at that TOT, so that we have resource to be able to train in country. And that was also across a few other countries that we're going to roll out CAP. So that happened last year. And in terms of now getting that step down of capacitating ourselves in country, we also had to work with Ministry of Health and other stakeholders to then also plan and also work on those materials to domesticate them to Nigeria. So there was a whole process of looking at reviewing the the materials, the TOT materials that were going to be rolled out for the country. So that held last week, and it's all part of that plan. And there are also going to be a series of trainings. I think the ministry has already sent out a notice. There will be further review of those materials, because the different phases, looking at the TOT materials for TOT and also materials for service providers, materials even for community providers, at different levels. So we're currently also supporting that process, including job aid, development, and all of that. So there are different levels of TOTs that are going to be held in planned, and only one phase has been rolled out. So that's in terms of capacitating the country. Again, we are also sitting on the committees that Mr. Taiwo has also talked about. Part of the UST is also, the USAID is also part of the National Prep Subcommittee, where some of these discussions are being held, supporting the development of the concept note and that protocol that our pharmacist Elemua has talked about for the country. That protocol is also still being developed, so we're part of and supporting that process strongly to ensure that we have something for the country. Again, in terms of structure, policy-wise, because the other thing that also came out very strongly was, yes, on what basis are we rolling out CAP as a country? Is it in the national guidelines or not? So there was also that process of supporting Ministry of Health to be able to ensure that we're reviewing our national guidelines to be able to capture injectable PrEP, so that it provides us a policy framework for us to be able to deliver or implement PrEP. And I think, as we mentioned, the guidelines have been reviewed, and it's also in the process of being finalized. I think I'll talk about also the fact that for PEPFAR, we will not necessarily be rolling out in all the countries, in all the states. We have so far selected one state, which is Lagos State, for the rollout. So we will be prioritizing that state, and a few facilities that, with certain criteria for that CAP rollout. So there are a number of things that are being set in place to be able to support and ensure that there's product availability, because that was also a key thing. We can't have a program if there's no So for us, PEPFAR, we are expecting the product to arrive in June, July. As at yes, as at this week we're here in July. So by July, the product should be in country. But we are working with all stakeholders, and I'm happy to see my colleague here as well, to ensure that we have the country is ready to to give the product when it arrives. I'm happy to also hear some of the comments from NASDAQ, and some of the things that need to be done as well. I think that engagement is being strengthened. But overall, all these issues are being addressed, including the supply chain system, ensuring that things are in place, to ensure that we have a successful rollout, because that is critical for PEPFAR, because it also determines further availability of products for Nigeria. I think I'll pause there and then I'll take some other comments later. Thank you.
Thank you so much, Angela. I mean, I think she just a round of applause for PEPFAR support. It's through PEPFAR support that we're getting the first tranche of CAB into the country, like she mentioned, sometime this year. And she also mentioned that it'll be coming. It's a small quantity, but it's going to be coming into one state. So I think that might allay some of Dr. Lelua's fear about a nationwide scale up. So maybe that might just be because she's talking about one state. It would just be like an observation. We can do like observe a small cohort in the facilities that it will be rolled out in. So maybe we'll circle back to that in the second round of questions. I'd like to move forward now and talk to Madam Florita from NAVMAS. Madam Florita is our online participant, and I hope that she can hear me because I'm about to read out your question now. Can she hear me? I don't. Can she confirm that she can hear us? When she start talking. They are telling us something. Hello, Madam Florita.
Go ahead with the question. I can hear. Yes, I can hear you. Go ahead with the question.
Okay. So as you've just heard, CAB is being introduced to Nigeria, and pretty soon we'll be receiving the first batch of products.
The audio is off. I can't hear anymore.
Can you hear me now? Hello, ma'am.
Go ahead. The audio went off, so maybe you come again with the.
But you can hear me clearly now. All right. Okay, ma'am. So, like I said, NAVMAS has been very involved in supporting uptake and effective use of oral PrEP. Now that a new product is being considered and being introduced in country, what do you think we can do in terms of community engagement mechanisms to support the uptake and effective use of this new product?
All right. Thank you so very much. Good afternoon, everyone. So, in terms of community engagement mechanism and what more could be put in place for the effective rollout of the CAB PrEP, it's important to note that community must be first. And this implies in getting the community stakeholders to be part of the process of the implementation science design, the day-to-day implementation of the activities of that rollout, including the monitoring and evaluation of that process. So what implies is that as the national stakeholders, NASCAP, the PIs and other stakeholders are developing the protocol for the CAP prep rollout, it's also important to start putting together the engagement of the community stakeholders to support that process. So this will also imply having a community advisory board or a community advisory team that is going to support the plan around the implementation of the CAP prep. So CSO engagement is very critical. CSOs have been able to demonstrate that they can make a difference in terms of promoting community education and understanding of HIV prevention, including the new effective tools. And the need to push advocacy for East rollout so that we are not left behind in the HIV prevention program. So we can draw lessons from the oral prep. We did the oral prep demonstration study, and we did have a robust community engagement program that supported that process. So we can do the same. We must not leave behind the adolescent and young women as we plan the CAP prep rollout. We must also understand the complexity of the community structure, looking at the cultural settings and the religious institutions, the role they play in supporting HIV prevention programs. So we must have a clear advocacy process that will create the needed awareness and support of these community leaders so that they can support our CAP prep rollout. Another key lesson over the years with our HIV prevention program is also working with various community groups and populations. So this includes identifying the women groups and civil society organizations that also work with women groups. We must also continue to identify the key populations, especially as the grassroots, looking at the CBOs that also work with these key populations. So capacity building and training is critical. I'm glad we are developing the CAP prep training manual. We must also consider that the community are part of that process, and we'll be able to design those materials to also meet the community needs in terms of CSOs adopting those training manuals to drive community education and sensitization on the CAP prep. You agree with me that it is not enough to bring in the products, especially if we do not drive the community education and demand for that product. We may end up having the product expire over the shelf. So this implies there must be critical plan and strategies to work with the communities, including civil society organizations, to support PrEP education, and most importantly, demand creation. I can share a lot of experience from the work we do as NAVMAS. NAVMAS have worked with the national body NACA to implement a very robust community engagement state. And we did work with them to drive oral PrEP education, create demand, and make sure that the project was a success. At that time, we worked with serodiscordant couples. And following that study, the CSOs was able to push strong advocacy to adolescents and young women. And today, so we have to repeat the same process. I would also like to share with you that NAVMAS is part of the global coalition that is working to support prevention research called, and we have implemented project with a very critical in every zone in Nigeria. NAVMAS have been able to form what we call the HIV Prevention Coalition. These are members of civil society organizations and interested groups that push research literacy education, as well as advocating for rollout of the effective tools like the CAP PrEP as well as the PrEP ring. Okay, beyond that, we also have what we call the learning program, which is ran behind. This is a program that NAVMAS runs with young people in Nigeria and and a lot of them have, prep.
Okay. All right. I think at this point we've heard a lot of what Madam Florita has said, but it's the next. You didn't quite get all of it. Well, I'm so sorry about that. I think the network, the connection was a little bit poor. But yes, she was kind of outlining some of the steps needed, to make sure that communities are engaged in this process and that advocacy is very necessary so that, and it's not just important to bring in a molecule or a new product, but we must also begin to think about demand generation and uptake. That's the only way that people will know to uptake the product. So thank you so much, Madam Florita. We're so sorry for the poor connection. Okay, so I'm going to be moving on, taking a different tangent, talking about another pillar on this product introduction framework, and I'll be asking Kemi from Chai this question, switching to the pillar of monitoring and evaluation and learning. So I want to ask Kemi, what steps should we take to strengthen our M&E system so that we can successfully support the gap for this market? So as everyone has mentioned, with the introduction of a new product, new direction from the for the country in terms of maybe guidelines, reviews, and things like very essential that the reporting tools have to be updated. We have to develop a set of indicators to be able to capture the service that has been done. This is then reviewed nationally. We know that the country usually goes through a process of okay, and this follows maybe a change in the direction of implementation or a new intervention being introduced. And so the tools have to be reviewed, the national tools have to be reviewed, and this is usually led by by NASCA in collaboration with other stakeholders. Aside from the tools, so we do know that we have the M&E tools, which more or less monitors the service data, and then there's also the logistics data. And so all of these tools have to be adequately updated to ensure that they can allow, CAP PrEP be documented, in terms of the service. Following that, after the tools have been reviewed nationally and through series of meetings and they've been agreed upon, there has to be printing and dissemination to ensure that they are actually at the service delivery point. So it's not enough to develop tools and leave them at the national level. It's if it's not at the service point, then it can't be used and you can't get information up, back to the national level decision making. And then we said a lot about capacity building. It's also critical that Once the new tool has been rolled out, there has to be capacity building of healthcare workers, or the M&E focal persons, or the logistics staff that have to document, the service uptake, and just so that there's visibility into it. So they have to be adequately trained to be able to use the tools, and this is usually done in collaboration with all. It's led by NASCAP and is done in collaboration with stakeholders. After that, we know that once the healthcare workers have been trained, the next thing is to collect the data monthly. So there has to be a support for the monthly collection of data and analysis, just so that we are able to have visibility into what the services are, also to identify gaps in implementation. So this will help with cost correction. Another level is the periodic review meetings that should hold. This gives an opportunity for stakeholders to come together and then see what or how well the drug or the commodity or the intervention is in terms of rollout. So, and this also gives an opportunity to, either for informed decision making, because you end up seeing the service uptake and also surveillance data. Dr. Uche said a lot about surveillance, so we also want to know that not causing any harm to anyone and things like that. Following that, there's usually a monitoring and supportive basis as well. This gives an opportunity to validate data across the respective facilities. Aside from that, gives an opportunity to interact with the healthcare workers, to provide on-the-job mentorship and things like that. That way, they're able to reinforce what they already know, and also that the service they're providing to the recipients of care is optimal. Yeah, so I'll just stop here for now. Yeah, thank you so much, Sherman. That was great. I listened to the panel that you moderated yesterday about strengthening M&E systems, and you reiterated some of those key points. And I mean, I think it kind of rings true across whatever intervention that you are putting in place in the health system. M&E, it's really the backbone. If not, I mean, like we say, whatever is not documented properly, it's not done. So yes, I'm so glad that you highlighted some of the points, and then also let us know what you need to do, what's really already being done in terms of strengthening the system to support that production thing. Okay, so last but not least, just there. Thanks for waiting patiently. Where the final, and I think it's a very key, I mean, it's a key pillar. I mean, Dr. Elumu already mentioned, talked about, what is the PSM's role in this? And Joseph will be talking to us about supply chain strengthening. And my question to Joseph is, how is the supply chain system currently being strengthened to support the introduction of CAB?
Thank you so much, Helen. And before I start, I just especially like to thank Lucy for giving us this opportunity to share our learning and to participate in this discourse. And of course, I want to thank the government of Nigeria for allowing us the opportunity to share little in the over 40 years of implementation in this country to contribute to the national plans towards the rollout of CAB over the past few years under the Global Fund and so under PEPFAR project. So we have actually partnered significantly with IHBA under the Global Fund to work towards this the plans towards commencement of CAB prep in the country, and also under the USAID KPCare projects. We have been able to ensure that we work with the country under the guidance of NASCAP to plan for the proper implementation. So I go quickly to the question by Helen. So supply chain management. Rightly so, you mentioned that it's actually cut across all the intervention areas. As a matter of fact, across the value chain for CAB prep, you will see that if you talk about the budgeting and the planning, for instance, the fulcrum of budgeting and planning for the implementation is the products, right? It's really important. Of course, the clients are in the center, but if the clients do not have the product, it becomes a problem. So it's essential that in the budgeting and planning that a lot of discussions and proper forecasting is done with respect to the commodity. Angela made a very important point that where there is no products, there's no programming.
And that's really important. And that is why at the very point of planning for this implementation, planning and budgeting, it's important that we consider the various indices of the products, the supply chain issues with respect to the product. And we also, of course, under the monitoring and evaluation, you know that we must have a target. We must have a population we are trying to provide these products for. And that's it's really important because we must be able to plan for the different category of persons that we want to provide the products for. That is very important. The M&E systems have to be hand in hand with the supply chain systems that ensure that these products are available. And of course, with respect to the service delivery platforms, what are the kind of platforms that we want to provide? Yes, the platforms, do we want to use public, we want to use private, we want to use community. All these platforms have implication for commodity availability, commodity security, commodity procurement. So it's really important that we all these are factored in. And of course, indeed, over the past few months and years that we've had this discussion at national level, there have been effective planning towards supply chain. Under the Global Fund, for instance, so we partner with IHBN and of course with NASCAP. They have been planning over the past, from the last round into this round, planning towards ensuring that products are properly products are procured, quantification and forecasting, and of course proper budgeting for the product availability, and then ensuring that this product gets to the clients. So it's really important that we target this entire cascade with respect to commodity availability, commodity accessibility, commodity cost effectiveness for the clients. During the presentation, Angela mentioned that the dose for the clients, for instance, about 600 milligrams for at start, then within 4 weeks or 30 days later, the client has another dose, and then you have probably a bi-monthly doses of 600 milligrams for about a year. So that would mean that the client has about 7 injections in a year thereabout. Now that's really important that we know how many clients, you know, so in procurement and supply chain management, for us to be able to properly quantify and make available the products, we have to be able to factor in the various parameters that the clients really have this commodity available. Now, all these discussions have been factored in, and we're quite excited over the past few months to hear that USAID had actually reached the point of bringing the commodity. While at the Global Fund team, we were discussing about how to procure. We are still discussing the Global Fund and making plans to be able to bring in the commodity. So essentially, for the PSM system for CAPREP, it's essential that at every single point of planning, all discussions about the products availability, production, in-country distribution, and storage are put in place to for us to be able to make available this commodity. Thank you.
Thank you so much, Joseph. I'm really glad that you kind of brought it home to the practical aspects of how many doses will the client need. It's a really new product, and I mean, I hope that that statement is very eye-opening for a lot of us in this room that are thinking about, okay, it's an injectable, you take it twice a month, but how many doses would someone need? What are the prevention needs of the person, or will the person take it for a year? Those are supply chain considerations. I'm so glad that you brought that home. So I'm going to open it up for questions from the audience. I think maybe just so that we're doing it in an orderly manner, like we did it in the opening session for today, it might be great for you to write your question on a slip of paper and hand it to my colleague, and then she can bring it here and we can pass it to any of the panelists that whatever pillar your question falls in, then one of our panelists will be gracious enough to answer the questions for you. So, okay, do we have a question already? Okay, you have it written down. I don't know if you want to help with that. All right. Maybe hand me one question so that. Okay, all right, you're still handing out the sheets. Okay, maybe we can go around the table again with brief answers this time so that we have time for Q&A. So, Mr. Tyrell, we've heard plans from from PEPFAR about what the products coming in sometime this year, and just let us in a sneak peek into what Global Fund is also planning. So there's lots going on in the prevention environment. And my question to you is, how will how will you use your good office in NASCA to continue to support this busy policy environment to make sure that CAB is piloted, rolled out, and scaled up effectively?
Okay, thank you, Dr. Again, once again. So the policy and India environment, we are involved in a lot of policy work in the ministry. As you are aware, our national guideline for prevention, treatment, and care is already developed, analyzed, but it has not come out. And we make sure that PrEP is pronounced in that guideline. The guideline of 2020 that was developed, it was oral PrEP that was included. But this 2024 guideline that will be out any moment from now will ensure that PrEP is included in this guideline. Not only that, all modality was put in place so that prevention was made as a chapter in that guideline. It was a chapter. It was not a chapter in the former guideline. So PrEP is included, PrEP is very spread out, and other biomedical options that will be given or will be rolling out later was also included. So apart from that, our PrEP implementation plan, the 2 years we had before has been exhausted. So we are planning another 4 years implementation plan also. That will be starting from this 2024 to year 2027. So that one is already in progress. Right now, it's already in the progress. So as my colleague also said, Madam Angela also said that our training manual, all that we had before was oral PrEP, and we are ensuring that PrEP is also included in our training manual. In anywhere from now, we will review the guideline. We will review the guideline. We have gathered all the resource material together. It's brought to call a stakeholders meeting, which we have notified them already, to come together and make sure that the training manual is reviewed. What is reviewed, we'll be using the training manual to train our stakeholders. And we're also planning to pull master trainer together. Pool of master trainer, want to train them on PrEP now, both oral PrEP and PrEP, so that they'll be able, to step down to training also to other people at the lower level. So for now, that is what we are doing. Thank you.
Thank you so much, Mr. Taiwo. Okay, we have quite a number of questions. I'm so glad you are engaging very much with this conversation that's going on. And there's I think it's a very interesting question. And even though I'm kind of worried about Florita's connection, but I think we have Madam Angela on panel, and I'm privy to the fact that she has done a lot of work in the OVC space. So maybe she can kind of try and tackle this question. The person is asking, how best can OVC partners effectively create demand for PrEP in the community? So I think maybe this is my own addition to the question. Is there even a role for OVC partners in this intervention?
Okay, thanks, Helen. Yeah, I think there's a role for the OVC partners in this space because they also work with adolescents. Even though, yeah, they work with adolescents and also the caregivers as well, And we also even have, within the OVC space, we also have adolescent mothers as well. We have some child-headed households. We also have, there's a broad spectrum of women and also men that as caregivers that we find within the overseas space. So I think there are opportunities within that to create demand within the community because the OC program is mostly heavy within the community. So that's one. Again, in terms of now also for even the adolescents that we have on the OBC program, I think the restrictions would be age of consent, which, as we know as a country is currently 18, that also can restrict adolescents that are at risk that may want to start or take PrEP in Nigeria. But to your question, really, yes, there's an opportunity for the OBC program to create demand for PrEP and PrEP. Thank you.
Which one? From Dr. Ayokami from Mixat. So I'm glad that you put your name so that we can acknowledge who's asking this question. Thank you for putting your name there. He's asking, how do we plan to manage higher demand against the limited supply since we are advocating for community mobilization? So that's a question about demand and supply.
All right, thank you very much. So it's good you bring it up on your. We are actually at the beginning of a small scale rollout of PrEP, and we know that at this stage we're going to work with a certain target number of samples of clients, target population. We have a certain number, and we're going to have, in terms of the PSM system, we're going to have a mix between a pull and a push system. We're not going to have a single system to make products available. We ensure that we have the precise number of clients that we're pushing these commodities out, and the clients are utilizing this commodity, they're in a position to ensure that these commodities are available. So it's going to be, it's not like a large scale rollout or implementation. We're having like a measured implementation. So it's going to be quite watertight at this stage. Angela already mentioned that USAID is looking at Lagos, and even in Lagos, USAID is not looking at so many clients for now at this stage. That will make the logistics system a little bit more manageable. Now, for the global fund system, for the number of vials that global fund is procuring is not so much at this stage. As a matter of fact, I wouldn't want to say the precise number right now, but then it's not so much. And we also know that global fund is only in 4 states. We are not sure yet if all 4 states are going to start. We do not know yet. So, but again, generally, demand and the demand creation, demand generation is not going to be much of a problem because of the fact that we are not starting very big yet at this stage. Thank you.
Yes, please.
So just to add to what Joseph has said, I think really from what we get within the community, we know that there's already a number of people waiting for CAB to arrive in country because of some of the challenges that exist. We're taking the oral PrEP, we carry the bottles around, there's intimate partner violence, the pill burden, and all of that. So a number of our clients are already waiting for CAB to arrive in country. So we don't foresee a situation where it will expire on us or there won't be people available to take on the little quantity that is available. Just to also say, I agree with my colleague, actually it's PEPFAR, not USAID. Okay, so PEPFAR has, in Lagos State, has both all our agencies working in Lagos State, and those are some of the considerations that we're giving in selecting Lagos State so that all our agencies, because it's going to be implemented across both CBC, USID, and GOD. So that's for Lagos State. The other thing I wanted to add is that even within the selected population that Joseph was talking about, which, like he said, the country is looking at prioritizing KP, those that really that need to be on PrEP. Within that selected group of persons or that target population, we're also looking at still prioritizing further, so prioritizing further to look at, because we don't want to start someone on CAR and the person stops. So looking even at our within our clients are on oral PrEP and looking at those that have been on PrEP longitudinally, that have been consistent, things like that. So those kind of considerations we're also working out and getting also support from our headquarters to enable us do the right prioritization within the priority population that are being prioritized for academic. So what I'm saying in essence is we don't foresee a situation where demand would be low, or we're looking at, we have these doses, and like my colleague said, it's 7 doses in a year. So that means we have to even start with a conservative number so that we don't run into supply chain issues where we run out of CAB for those that's supposed to take for 1 year, because currently in country, currently across the world, there's not enough supply. I'll pause it. Thank you.
Great answer. And so there's no worries about the demand. And there's already a lot of consideration around who's going to get the first few doses. It's a limited supply, so we're not going to be going around the country doing mass demand generation for CAB, as we've just heard. It's going to just be, focused solely in the few facilities where the product will be first rolled out. Thank you so much. Yes, ma'am. Please go ahead.
So, all the contributions, I think it's becoming clearer. Now it is known CARB is injectable, and it's good we're introducing it into Nigeria. But I want to also reiterate at this point that it is still critical that we look at the safety components, because looking at the African Union Smart Safety Surveillance, CARB PrEP is one of the products that we're looking at the continental level for Africa in terms of gathering safety information, so that, because we know that the ultimate aim for the African Smart Safety Surveillance, African Union Smart Safety Surveillance, is to develop the African database, which houses the continental safety monitoring data, both from the clinical trial point of view and post-use. So it will be critical at this point for us to all agree that for this introduction in Lagos State, no matter how the numbers are, we must put in the active monitoring component, because that's the only way we can actually capture what the safety profile will be within our own population, so that as we are looking at in-country data in terms of decision making, we'll also be able to contribute to a continental database where we do signal detection, signal management, monitoring and detection, and otherwise. So I think no matter whatever it is, only Lagos State, we must institutionalize the active monitoring right from the start, because that will give us good evidence-based information for any regulatory decision making, whether to continue to allow that product to be in the market and in our own space in country for use or otherwise. So I think at this point, also we need to put that into perspective. And another thing I want to find out from ID, like what's the conflict of the type of infection and how many patients, how many Claire, are we hoping to target during this pilot phase? Because that will help us to start thinking of our heart. Okay, thank you. So for PEPFAR, we will be getting about 15,000 valves, right? So and approximately we're looking at about 2,000 persons. So approximately about that. But like I mentioned earlier, we are ensuring that we are conservative in the number of people we start because the product is not available worldwide. So we ensure that clients that we start are able to get the doses for at least a full year until most likely we get the next we might get the next supply. But you know, ensuring as a country that we have everything in place, including all the regulatory approvals that you talked about and all that in place, which I know NASCAP is working hard on, is critical for additional increased supply to the country for PEPFAR. So we must demonstrate as a country that we are ready, we are able to, absorb more before we will be giving larger quantity. But for now, to your question, that's the number. Thank you.
Yeah, so let me just, thank you so much, Angela. Let me just add for Global Fund, like I mentioned earlier, the fact is that Global Fund is willing to ensure that we get commodities in through that funding stream into the country. IGM is the principal recipient, SFH and the other partners, AQs, and we will be working very closely with IGM to ensure that the commodities are in country as soon as possible before the end of the year. This stage, we don't have a specific number yet. We're still working with NASCAP and the National Prep Committee on that. And I'm sure that while those discussions are ongoing, all stakeholders will be brought to the table with respect to the specific numbers. Thank you.
I hope that answered your questions, ma'am. Thank you for introducing those questions. I think those are like really practical questions on the next step. I'm glad you asked those. And you had already started talking about monitoring for adverse events, for monitoring persons that are using this drug. And so I think that's a great segue to a question that was addressed specifically for Kemi because you need a strong M&E system to be able to capture the kind of data that Dr. Lema is talking about. If you don't have the kind of systems that will be able to collect all of this information, probably can't even transmit it or put it to any good use for either nationally or globally. So they're asking if there's any innovative approach to cap prep data management. They're asking if we envisage, if we're thinking about any innovative approach to cap prep data management. They had that, they had when you were talking about primary data collection tools and the rest of it. Can we leverage IT to make data management more efficient and effective? And I think this is like a bonus question. How will that data then align with defined data repositories? Thank you very much for that question. I guess while I was responding to my question, I didn't really, portray the fact that the tools that we're talking about actually exist in paper-based and electronic. So we know that the country is already moving towards the use of electronic reporting platforms. And aside from that, across the country, we have sites that currently have the electronic medical records. The national program currently has a reporting tool that is being used at the health facility level. It's electronic. It's more or less like the DHIS, where you can report data directly to the national. So all that needs right now is just to be updated with the indicators for CAP. And also optimize that for oral prep as well, because we know that there's been a challenge for reporting even for the oral prep. So we need to do a whole lot more to ensure that there's visibility into the prep data generally, whether it's oral or CAP. So yes, there's an electronic platform that they'll continue to enhance to ensure that it covers or captures both the CAP prep and oral prep across the health facilities, and that way it can be easily transmitted to the national level for decision making. Thank you.
Yeah, and sorry, can you just add also that as much as possible, we do not want to create parallel systems, right? Yes, the new agents coming to the country, but we already have PrEP in the country, and there's already a platform that's oral PrEP is being reported, and the tools are being used probably to make one or two tweaking, but we don't want to create parallel platforms. Likewise, the procurement and supply chain management. We're not going to have a separate storage, separate warehousing, separate distribution for Kabeli. We already have a system that is being operated by the country. So it's as much as possible, there's going to be integration into already existing systems. Thank you.
Sorry. And in addition, we know monitoring and evaluation is the bigger one. And adverse drug reaction reporting is also part of that monitoring and reporting, which will inform decision making. We also have the electronic reporting platform for adverse drug reactions, because as much as we will do an active surveillance, but the passive monitoring surveillance is an ongoing thing that every healthcare provider, even the patient, is responsible for. So we have an electronic reporting tool, which is called Med Safety app. It's downloadable through the Play Store for those using Android, or iOS for those using iPhone. Once you just go there, you just click Med Safety app, and it brings it out to download it. That is the advanced drug reaction reporting form, the paper form, transcribed into an electronic reporting form. So as much as we capture, we asking for active monitoring, passive monitoring for adverse reactions are ongoing, because we have identified from literature that some of the reported serious adverse reactions associated with CAP, issues of hepatotoxicity, hypersensitivity reactions, and depressive ideologies, suicidal ideologies. So these are things that we need to actually pay attention, because as much as we want to prevent HIV from escalating, we also want to be sure that those that are using it do not come down with adverse reaction, because you know that that's one thing that will stop people from even using the medication. For as much as we want to create high demand for its uptake, if people begin to experience a lot of adverse reactions without it being monitored, it will also really affect uptake. So it's very, very critical that we need to think about that. So the Med Safety app is at the disposal of everybody, both the patient, both the healthcare provider, and everybody can use. Once you download it and you have an adverse drug reaction at the corner of your house, in your office, in the health facility, you can actually take it, and it's an online real-time reporting. Because once you do that, immediately you click submit after filling the form, I get it automatically in my database, and there are desk officers monitoring the database to see whether there are serious reactions and give feedback, so that for immediate decision making about the use of different products that were allowed for use in a market. Thank you.
That's a great, thanks for letting me know. That's, yes, you can applaud. I mean, that's something I just learned about, and it's fantastic. But just a quick question: is it possible? So, if as a facility I'm a provider, you just said I can enter the data. Can I then pull, aggregate, and say, okay, I want to see all the forms from everybody that has filled any kind of adverse drug reaction for CAP, and then we can pull that data? Is it possible?
Yeah. Because once you fill the form through the Med Safety app, it enters the national database, which is called Digital. So totality assessment is done. We can actually pull out all data from everybody across the country, different states of the federation that are using the product, and we can actually do an assessment on that.
Thanks for letting us know about that. That is wonderful.
it just shows how far we've come as well as a country in terms of pharmacovigilance. Okay, I have a question from Mr. Taiwo. I think you'll be excited about this question, Mr. Taiwo, because this is something I know you've been championing, and we've had a discussion even personally and in the group setting about this. The question is, how do states SACAs key into this laudable intervention?
So, state soccer, they are other part of that operation. Because anytime we carry out our MSSB to states, both representatives of SACA, representatives of SASCAP, the IP in the state and national team, they are always part of that MSSB. So they are part of that innovation. Because anytime we go for MSSB in the state, and last time MSSB we went at in those states, we even asked for their readiness for cap prep introduction. And they were very happy. So Kappa is one of the team. And like you said now, they have like 8 man, I think they are 12-man team now in the state. The 12-man, right? Yes. That they meet regularly. They meet regularly concerning all these things. And anything Saka is doing in the state, SASCAP is doing in the state, everybody is aware. Thank you, man.
Thank you so much for that response. Okay, I have a question here, and I'm going to just put these two together because I think they're kind of related. It's a follow-on question from Dr. Ayokami from ICSA, and he was asking about switching from oral prep to injectables. He also asked a question around choice, and I'll just add this other question because this person is very worried about what's going to happen to TDF pre-TC that we're currently using. So there's a little bit of concern around, are we dropping oral prep in exchange for the injectable? So I'm going to throw it open to the panel. Whoever wants to take this question, you feel free to. Sure. Okay. Mr. Taiwo, you want to take the first stab at the question?
Okay. Okay, just let me talk to this. We are not abandoning the TDF base for now. We are not abandoning it. It's a choice in the house. The choice is on the table. Which one do you prefer? And we have a lot of counseling session. It's like HIV test. Before you go for the test, the counselor tells you, you have the informed decision. Nobody will force. So the options are there. Oral prep, CAP, LA is there. So there is I think it's part of the training that you'll be exposed to later on now. Part of the training. Now, if you are on CAP prep, for example, and you told your provider that you will be away, for example, today is May 8, right? Okay, you told your provider that you'll be away till July 30th, and your next dose supposed to be in a month's time or in 2 months' time. You told him that this is what you do, and you will not get around to take that injection after that time. So he has the option of giving you the oral prep, another piece to taking during that period. So when you resume back on the appointed date, now you give your own CAP early, then you continue. But if you discuss with your provider that this is what you are going to miss that appointment date that has been given to you. Dr. Joseph talk about July. Yes, he told that, oh, on the 8th of May, June, July, I will not be around. I will not be around. And how will I do? I'll be coming back in September. So the provider has a chance or that leverage of giving you oral prayer in that period. Thank you. Can you understand? You see?
Yeah, thank you. I was just also going to add to what Mr. Tyler said. With oral prep, we know that it comes with a lot of challenges. You know, we talked about people being stigmatized for carrying their bottles and things like that. Also, in terms of convenience, when you look at the dosage, people have to use it daily. But with the what's it called, with the injectable, it's, it gives you a longer period to actually take the drug. So we think having options, on the it's a very critical thing, and it's not only for prevention, it's also very, uh, some of these concerns around, maybe, I think we call it risk compensation, better HIV prevention methodology, especially for young girls.
Okay, let me just have a question on it because it's time that you have, I'm sure, anything I said to spoil me. Yeah, because this is a discussion that we've had encouraging AGY. But again, we also understand that we have emancipated minors, right? Emancipated minors. We have partners of AGYW, who are also prior to AGYW. So I think these are discussions that are still ongoing, and I believe that as in the field, it will be communicated as the as the conclusive discussions come up.
Check what's on that.
I think awareness creation is very, very, very key.
Go ahead. Of course.
Putting out the right information is very, very key from the beginning. When people will begin to look at
choices, providing more choices, providing more options rather, for people to make the choice of what works for them. The truth of the matter is, we have a broad spectrum of adolescents. And sometimes we are fixated in our own comfort zones, thinking of the fact that, these adolescents are just, okay, my children only. I look at my children and my children, just sampling some of us sitting in this room. So there's a broad spectrum of adolescents that exist in Nigeria that this can be upheld to, so making it available is not necessarily promoting promiscuity, which we see that even making available condoms has not necessarily done so, making available, yeah. So I think really is to open our systems in place rather
and Development, West African Center for Public Health and Development.
Please, can we see?
The title of that section.
Let's confirm.
So the title of that section is Evidence Generation and Use in Improving Quality of Key Population Program, supported by the West African Center for Public Health and Development. So that section will be starting at 2:15 and ending at 2:55 on the dot. 2:15 and ending at 2:55 on the dot. After that, we'll have the SFH section, SFH supported section. The title of that section is Future of HIV Financing. Does it have a cost? The future of HIV financing. Does it have a cost? And that section will be starting 2:55 and ending at 3:55. 2:55 and ending at 3:55. Then other sections will follow immediately. Please take note. Thank you. If you want further clarification, please contact the scientific and technical chair. God bless you.
Thank you very much. We just came for that information.
Yes.
Thank you very much.
Okay.
So this volume is the system. What is system? Hello? If it is a system.
Yeah, it's not system. So that speaker as close to my system as possible. That speaker cannot move, but cannot move. Well, see, what's that? Why is everything done? Please check the audio. My audio from your from my laptop. It's not from to you. My audio.
Yeah. Please, let's sit. Let's calm down. This session is starting exactly at 2:15. Please, let's sit. So evidence generation and use.
Hello, are you still up? Are you still up? Where are you? Where you there? So where is Sylvia? Can you please help me send our number? Everybody should vacate that lunch place by 2:10. That's how I did that.
Sorry, sir. I don't know whether you have a presentation.
The laboratory branch chief, UXCDC Nigeria. You're welcome to the session, sir. Just seated very close to him also is Victor Adamu, team lead, community and gender services, also from the USCDC Nigeria. You're welcome. And then we have a lady who has, I must say, traversed the length and breadth of public health interventions in country, especially within the HIV and viral hepatitis space. She's from the WHO, Dr. Olufunke Iresani Obinladi. Dr. Funke, you're welcome to the program. We equally have from the community. I hear it's been resonating strongly from yesterday in all our discussions that community engagement is key and critical in all of this. So we have the National Coordinator, KP Secretariat, Christopher Tessa, seated on the panel. Chris. And then Dr. Patrick Ekani is of Genesis Analytics and also from the SSLN Learning Platform. Patrick comes in with a whole lot of implementation experience, of which we get to hear as we engage in today's conversation. Dr. Ekani. Session. Also, so it's important to reiterate that this session is being sponsored by the West Africa Center for Public Health and Development. And over time, working with the parent body, the institute, there's been a whole lot of evidence generated, especially within the key population space. Dr. Kalada Green will take us through, and then we'll leave the chair to moderate discussions. I'd like us to be lively and make it all participatory as we work within the limited time that we have. Thank you. Dr. Kalada, over to you for the presentation.
Thank you very much. And Good afternoon once again. Again, let's apologize for the mix-up. We hope people won't come back to say that they missed our session, but we'll have the recording sent. Canada, country coordinator for West African Center for Public Health and Development. I'm also the country director for the Institute of Global Public Health, University of Manitoba. We want to acknowledge the online participants. If you're part of this, we want to welcome you to this session. Like I said, even though we're starting with shakiness, but I'm sure we'll get there. I'm going to take you through the evidence that's been generated in the country in the past 10 years, 10 to 11 years, in an attempt to improve the quality of key population programs. And it's our hope that when we go through this, the panelists will then discuss and then look at insights on gaps in evidence generation, gaps in evidence use. The aim of this session is to highlight the importance of generating quality evidence, using quality evidence in improving the program in the landscape of HIV for the country. So I'm going to start. Can we have the first slide, please? I'm going to start. Next slide. I'm going to start with giving us an idea on the issue of quality data in evidence generation. Quality data dimensions entail that the data have some level of accuracy, reliability, completeness, precision, integrity, and timeliness. And when you have high quality data, it can be used for evidence-based decision making, especially now in a situation where our resources are being challenged every day with diminishing resources, but increasing need. There's need for us now to begin to use evidence and emphasize evidence in effective policy making, resource mobilization, and also program planning and implementation. So the onus is on us to ensure that we generate high quality data and use it. Next slide. Evidence is important for analysis, dissemination, collect data. Next slide. Now, within the past 13 years in the country, what's happening to this? No. Within the past 13 years in the country, there's been an attempt to generate data to guide key population programs in the country. And this effort has been led by NACA, NASCAP, the government agencies, but it's been well supported by our partners who have seen the need for quality evidence. So in the past, we've had to do epidemic appraisals. Epidemic appraisals were to help us provide critical information for program planning, including targets in a very mixed and heterogeneous epidemic in the country. We've also conducted ethnographics, which deepened our understanding and provided a deeper view in our local social, cultural, and environmental dynamics. It's related to sexual relationship practices, networks, and patterns of vulnerability of HIV infection among key population. This ethnographic study was conducted in Abuja within the sex work community. We've had series of integrated biobehavioral surveillance surveys ranging from 2010, 2014, 2020. The last one was 2020. It provided information on serological and behavioral aspects, including service coverage for key populations in the country. We've also conducted site estimations and provided information for planned target setting, HIV programs, mapping of key population, and of course, characterization of key populations, not just in terms of typologies, sub-typologies, but also profiling the venues where these key population groups operate, understanding the nuances that surround their activities to improve our program at micro-social level. What I mean is at the hotspot levels. And then we've also carried out some pilot studies. The institute functioned by carrying out pilots and then making recommendations for scale. The new answering program that was piloted by SFA was evaluated to provide further insights for people who inject drugs. So since the past 13 years, these efforts have been made to generate evidence and have been used continually to reshape the landscape for programming for key population. Next slide. Now, for us to generate evidence, you need to have a framework. And on display there is a framework where you look at what and what should guide the evidence you're generating. The effort has been to make sure that the evidence we generate has an international dimension in terms of standard, in terms of quality, in terms of, importantly, the indicators you're measuring, for us to be able to be counted amongst nations that are responding to internationally recognized indicators to measure our efforts in programming and also to measure our efforts in policy dimensions. So over this period of time, we've been involved in looking at program indicators, determinant indicators, behavioral and outcome indicators, and then looking at impact indicators. Next slide. And these are the indicators. These are some of the indicators that meet with international standards that efforts have been made to collect income to ensure that we use it to influence how programs are being implemented, but importantly too, to use them to mobilize resources. Next slide. This is the footprint of efforts across the country in generating this evidence. I'm running through this because of time, so that I'll have enough time to discuss. And if you look at what is on display there, there's footprint evidence generation across the country. However, the quantity and quality of evidence that differs within some geographies. Some of the epidemic appraisals were done in few states at the start out, but however, over time we've improved to make sure that we have greater footprints across the country, considering the diversity within the country, not just the north and south diversity, but within each geography there are diversity. We try to respond to this by ensuring that in every effort that is made to generate data for key population, these considerations are taken in. The diversities in geography, the diversities in characterization, the diversities in cultural and socioeconomic practices, to ensure we have a richness which, when put together, will give us a better direction on how to implement our key population programs. Next slide. So initially, from the epidemic appraisals in 2013, we were able to estimate sizes, but these epidemic appraisals, like I said, were mainly within urban centers. But over the years, we improved. With the last size estimation we did, coverage was across 20 states in the country. Sizes were generated for key populations, and this formed the bedrock for improving key population programs, including improving the planning for key population programs. We looked at high-risk venues in urban centers and then came up with the characterization. Next slide. Some of the evidence are those displayed on the board for the Mainland Series Program pilots. We looked at those who are sharing needles, and then looked at those who had knowledge about the effects of sharing needles and HIV transmission, including viral hepatitis. And then also we looked at insights of stigma and discrimination towards these key population groups and the influences of those on programs. Next slide. From the IBBSS, which is the latest, it's important to mention the 2020 IBBSS was done after a period of close to 6 years when there was no IBBSS in the country. And the findings were very informative. Importantly, those findings are being used now to reshape the landscape for programming. The IPSS is about the largest study that is done for key population groups. In the last one, it was done to ensure both geographic and regional representation with an insight to making national inference. And, we saw movements in prevalence across the key population groups by typology and even by sub-typologies. Next slide. And then from the key population size estimation in 2023, we're able to look at characterization of specific typology of key population groups. What you have on the board is for female sex workers, looking at their sub-typologies, street-based, brothel-based, nightclubs, casinos, looking at the distribution across the geographies that were studied. And also looking at the pattern of practice, daytime, evening time, night time, and then looking at their sizes at, like I said, micro-social level and the spot level. And then we're going to provide density information for these population groups across the states that were studied. This was repeated for MSMs, next slide, and also repeated for PWICs, next slide. And interestingly, the transgender were now included. The transgender is an emerging group in the country's national response key population programming. And, in the last 3-4 years, they've been involved right from the IBBSS, size estimation, and the findings have been quite informative because before this time, it seemed as if the group didn't exist. But now we have data that characterize them down to the LGA level where they are, both in terms of number, in terms of characteristics, and then in terms of other practices. It's important that after generating evidence, they have to be used. These are some of the efforts that use producing the national HIV prevention policy guided by evidence generated, national strategic framework, and other policy document. Was important to have partners who are using this data for their programs. I think they're here and they'll be talking to us soon. Next slide. But still, there exist gaps, both in generation and use. Some of the quickly identified gaps should be plugged to ensure that we have robustness in what we're doing for KP. Will include ensuring that the next round of IBBS has greater coverage than those 12 states that were done before, based on regional representation. So it will be nice to see 36+1 states IBBSs, further deepen understanding of HIV/AIDS amongst key population. It will also be interesting to have ethnographic studies which give us richer context for each of the typology groups. We should explore qualitative research to look at social determinants and structural factors influencing HIV risk and vulnerability among KPs. And also look at cost effectiveness dimensions. I'm happy Jepu is here, and he's been involved in the HIV/AIDS funding landscape. So we have to look at cost effectiveness because, like I said, our resources are dwindling. And then we have to do some more of value profiling to have micro level data, hotspots for further characterization. Of course, one of the greatest challenges we have in the country still remains the issue of the use of data in planning our programs, in mobilizing resources, and in policy making. That is a huge challenge, and I hope I see Dr. Bash here from the Federal Ministry of Health, NASCAP coordinator. I hope governments will take this forward and begin to ensure that now that the country is generating better quality evidence, this should translate to not just policy, but also to resource allocation, resource mobilization, program implementation for us to have the best benefits for Naira and those different programs. Thank you. Thank you very much. I'll hand over to Chair McPaul to lead the discussions on this. That was just to give us an insight of some of the strides on data. Thank you.
Please, another round of applause.
And let me welcome each and every one of you, and thank you for making this section the first section of this time. Operating on a very limited time, and we leave here exactly. With that limited time, and bearing in mind of what to make it as interactive as possible, I want to begin to introduce our panel because this are the welcome again, and thanks for availing us the opportunity. We have some great it's not support one thing that all the examine.
Is it not close to the mic?
It's a live.
No, it's this sound.
I know if it's not close to the sound, I think stop the comment. If it's close to the mic, maybe I stop.
It's like flying line. So that is my one is not very would you say influences your decision to fund or support?
Very cool. No, that's not good. Okay. There's no come on actually.
But maybe I can't move.
Support development country, the member state country. So having said that, the national strategic plan is quite important when we think of what to do as regards each program area, which in particular we're talking about key population programs. And in the national strategic plan, the national strategic plan is not complete unless it has targets. And how do you get the target? You get the target through data. Like you said, if you don't have data, programming is not I heard, they said. It's important for you to have information which has been generated from the different aspects, either from service delivery or from the population or from anecdotal information which you put together, and then you're able to get your target from there. So if we don't have targets, saying this is where the problem is, if we don't have information that is directing us to say, even among the key population, these are challenges for each of the psychology, then it will be difficult for you to just go blindly to go and support an implementation. And that takes me back to the first thing which I said about the national strategic plan, and which includes the target that we set. And how do we get the target? We get it from different information that have been generated from the different, maybe service delivery, population data, and so on. We put everything together, and then we're able to say this is where the problem is, and then we're able to go there and address the issue. Thank you.
Yes, thank you very much. There is no way we can achieve our 95 by 2025 without using data to guide us. That said, I'll move to you now, Victor. Looking into the future, what role do you see evidence generation playing in development and implementation of POPI programs? And how do you encourage the use of evidence for policy and program at CDC?
All right, thank you very much. Like Funke said, we can't do anything without data. All right, data is at the fulcrum of all that we do. It helps us understand the problem, helps us understand the scope of the problem, helps us understand what gaps there are, all right, in reaching solutions to that problem and helps us understand what we need to do more to achieve those things. So in looking into the future, there's no way we can put aside the issue of data. Data will help us program better for these subpopulations because if you see the evidence that Canada just pointed at, it just shows us, look, there's a estimated size of these subpopulations. There's some level of disease burden among these populations. And that is where we should focus, all right? Because this serves as a kind of fulcrum to give us direction in what to do going into the future. So I would say that going forward, there is no way you can do anything without data. And if we want to get our program right, we need to get our data right. Because without proper information on what gaps are, on what you've done so far, you're just groping in the dark. We need to know what the gaps are, what we've done so far, and what remains to be done for us to achieve the goals that we set up initially. So I think data is key to everything. Thank you.
Back to that, and basically, Dr. Shola did that gathering in his presentation talked about the fact that now we have the population data for key population. But he also mentioned the need to have other studies, ethnographic studies that would actually help us to have more information. In addition to that, I would say we also need more information on the financing. How much of the money allocated to HIV actually goes to the population program? And also the supply chain. How many of the products are actually for key population and the utilization as well? So all this breaking it down, because what we focus on a lot now is more like the population data. But we need to break it down to the mining, to be able to have this data from the different aspects and pull it together for us to look into the future. Thank you.
And let's quickly move to Elfa, who represents the community. So from the community perspective, how has evidence generated from studies such as those presented by Dr. Louise help the community understand the needs of key population and what changes have occurred having delivery over time?
Thank you very much for that wonderful question. The importance of data cannot be overemphasized. Data provides a clear direction to where programming goes, and that implies that data also provide an avenue where actually channel our resources for effective use. I will give you an example of the IPBSS. The IPBSS provides a clear prevalence of HIV down to the local government, meaning that for you to invest your resources in the HIV response, you must first of all look at the priority area where there are high level of prevalence, especially in the face of these dwindling resources. And then beyond that, what have collection of data helped us to do? It has helped us to also look at the issues affecting key population in Nigeria. And this survey has also helped integrate harm reduction services in Nigeria, although the coverage is low, it's limited to global funded states. But if we actually want to accelerate the process of epidemic control, then definitely we must extend the coverage of harm reduction in Nigeria so that exchange of needle and syringes will also put a stop to that. And the integration of viral hepatitis also as a result of findings from this survey. That's why I said from my opening remark that the importance of data cannot be overemphasized. Before now, people were not talking about TG, and when you say they exist, they will ask you, where are they? But with the coming on board of this IBBSS, it is clear to everyone that we actually have the country, and they can be programmed for. Thank you.
Thank you. Thank you very much. Might I ask that you kindly help us reduce the noise so that we can hear what the kindly, please. And in a moment, we will come over to you to get your own perspective and contributions as well. So please kindly oblige us. Let me now move on to data generation, making sure we're using this data to inform program of this. So what strategy do you employ?
Thank you very much. And thanks for the opportunity. It's off. Okay, so it deepens our knowledge of the program in terms of prevalence, in terms of our clear understanding of risk influencers and whoever. And at the level of the IP, see, the targets are placed vis-a-vis that. So it helps you to also measure effectiveness of your program. It gives you crucial insights into your prevalence and then looking at how you achieve results. So at this end, it is very, very critical that data use is not. And how do we do it? We do normal monitoring and evaluation. So we have tools, we have everything. But IBPS stands as a very bigger guide, and all these surveys, population-based surveys, help us to look at demographics. It helps us to look at the needs of each of these population from those studies. So those are teased out, and when you come to that side where you implement, you begin to look at how they play out. So day by day, the dynamics of these subpopulations and their behavior are also monitored, and that helps you in modifying your programs towards effectiveness. So data is quite critical from surveys down to program level. So program data helps us to also validate or look, serves as markers for us at the program of implementation to look at whether we're looking at it mimics what is national, working from the surveys, and then this helps to also or government to look at what they can do. So data, the role of data is quite critical and cannot be overemphasized. Thank you.
Thank you very much. We are aware that the HIV program has evolved beyond 30 years and continues to evolve. Today we can talk about non-transmission of HIV, especially for those who have achieved some viral suppression, and how this plays out in HIV population. It's something we need to monitor closely because this is something that will enhance the livelihood of the population. And if you look at the presentation over time, from as early as the data showed to 2024, our HIV prevalence amongst AP have always tended to look at HIV prevalence. Therefore, AP population, given the nature of that population, what may be better trend monitoring incidents? How can we begin to look at transforming our studies so that we're getting incident data, reliable incident data beyond prevalence, given where we are? I think those are some of the things we need to begin now to open up the space for. HIV genomic sequencing is now available to us as a country, but this is a technology we have not taken advantage of. To begin to ask ourselves, the HIV type in a particular individual, is it the same, or are there some mutations that we need to now evolve our programming and program the lead to be able to make sure that we are also targeting those mutations appropriately? Those are also questions we have not asked enough, especially for the key population group. I will at this moment want to acknowledge the presence of the NASCAP coordinator. We're happy you made this your preferred session. Yeah. We have few minutes before we begin to take questions, so we want to give you the opportunity to make few comments or even ask questions before we throw it out to the audience. Thank you.
For that, parent have a structure. We have stakeholders in the 36 states. And what we normally do at the end of the month, especially in those states that we have implementing partners, and they share their data together with the stakeholders and in those states. Give example of Bedouin and give example of Ondo and other states. So on our part, what we do is that we request for those data at the secretariat every end of the month to be able to monitor what is actually happening in those states. So what we need to do again going forward is to ensure that we get those data from either PEPFAR and the Global Fund, because the challenge has always been that we don't usually have the data to really monitor progress. And if you don't have data, how are you going to measure your progress? It is not possible. But we are writing to Global Fund, writing to CF, to provide us with those data. And then we can as well hold the IP responsible for what they do. Thank you for that.
Great, thanks so much. Part of the assessment, I'm not sure we're also doing very well. Assessing access to quality service by KP population. And by access, we're not simply asking availability of that service or package of service, but whatever the quality of package of service we have, if the beneficiaries are not able to get it in the form it's useful to them, and are able to use it in a way that impacts their well-being, then access is still questionable. To what extent are we assessing this and using the outcome of those assessments to improve our services to the patient population? These are also questions that we need to begin to ask. It's not just studies on prevalence, studies on needs. This critical basic question about are we reaching who really need these services or the people who need this service package? And in the form of the delivery that we are currently implementing, the way that it's suitable for the population we serve. These are all some of the questions we need to, and formulating these questions in order to enable us to generate the appropriate answers or data will require the KP population critical involvement in crafting out the questions. And again, that goes to the question. Let's keep that in mind. At this moment, let me read out one or two questions we have and then throw it over to you. Comment or question. What intervention packages are in place for people?
aware that NACA and NACA, of course, they work together on the response, and I'm aware that NACA had at one point focused on people with disability, but I think it's also, if you look at some of the current government policies in terms of even non-health, focus is prioritizes a lot of the people living with disabilities too. So in terms of study, I know DACA has the data, the information precisely on how the responses among the people living with disability in Nigeria. And I think yes, also we contribute to this discussion. So I know this is the area and they respond accordingly. Thank you.
Like I was saying, inclusiveness is part of the standard for programming in HIV, both health sector and non-health sector. So in all the standard protocols, everyone is expected to ensure inclusion, especially of any sample, the population that you are going to be implementing your services on, and ensure that you bring in everyone and ensure no one is left behind. That's the standard. And in all the technical working groups, especially those ensuring rights are upheld and everyone is, it's gender and human rights, for instance, they are part of it. And that's one of the reasons why you have an interpreter here for those with any. I'll stop at that. Thank you.
Attention, please. We're expected to end this session in the next 5 minutes to create time for other sessions. Thank you.
Okay, sorry. Let's just add it to what you have said. Let me use this opportunity to commend the University of Manitoba for the engagement process. Because if you look at the formative stage of any survey at all, the network is contacted. And then members at the subnational level are also part of the survey. I was privileged to be a supervisor during the IPPSS with other members who are also seated in this hall. So I think if other implementing IPs can borrow a leaf from this, put us in the program design, put us in the implementation, we can also do the monitoring together and proper solutions to some of those problems because we are the community and we have the solution. Thank you.
Very much. Thank you. Because of our time, I'll just read out one more question and then we begin to round up. An interesting question from the audience. When the data and anecdotes disagree, who do you stay with? Data or anecdotes, and why? The answer is certainly data. But there's also what is called triangulation. But unfortunately, we don't have much time to examine that. But data certainly is. The why isn't the data, we also need to triangulate. And that's also the, where the population, the community will serve comes in. What are their perceptions? And that helps you in triangulating those feedback and comments and issues related to you by the population we serve with the data you have.
With that said, we've been told it's already 3, and we are very sensitive to time. So we want to thank each and every one of you for making our time to be part of this discussion. Unfortunately, time is insufficient for us to go through all the questions we have. But I think this is a stimulation of what we need to be doing more. Having a section that explores what we could do in terms of data generation, but not just generating the data and the right data, but making sure that those data are informing policies and program change. Again, thank you to the University of Manitoba for hosting this session. And thank you all for your participation. And thank you so much for our excellent panelists. Thank you and enjoy the rest of the session.
Thank you very much. Thank you. We're also very grateful to the panelists. Thank you. The next session, I think, is by yesterday. We can all be seated for that next session also.
This is an invitation for the
Okay, can we please settle down? So the next session is on HIV financing.
Okay, so you said if I come here.
You don't leave it there. Just when you go for it, don't click on it.
Okay.
Press X. So don't click on it. That's why. Yes.
Okay. So when they ask for the slide,
She'll bring it up there. Just.
Okay, I'll just be navigating it.
Yes, one minute this year.
This they should all also and then because going to affect twins and see.
This one.
Radio section. Because it's still the same there anyway. The second section.
The session is going to discuss the HIV financing. Like we all know, everything that we have been discussing from yesterday to today, without finance, you know that it will just be a wish. And I want to invite the chairman for this session, which is no any other person than the national coordinator for NASCAP. Can we please put our hands together for him? From the speakers, we have Dr. Francis Ukuje from WHO, the health financing specialist. We have Dr. Kofi from National Health Insurance Authority. Okay, Dr. Kofi is here to come, so he will join us. Okay, yes. We have Dr. Maurice Atoki, Chief Executive Officer, African Business Coalition for Health.
Okay, that's actually what I did.
Dr. Maurice Atoki. We have Dr. Usman Bashir, the Director General, Kano Saka. We have Dr. Chudunga Ohazurike, the Senior HIV Specialist from USAID LSSS.
But 1 minute. That Francis presentation is for this session.
So this session is going to focus on reflection on our journey, 30 years journey of HIV intervention in Nigeria. So 30 years of HIV response in Nigeria. And within these 30 years, studies have shown that we have not done very well as a country in terms of our domestic financing. And from the different statistics we have, from the different studies, between 80, in some studies, up to 90% of the funding is heavily dependent on development partners, and especially the USAID paper funding and then the Global Fund financing. So this session is going to examine what can we do differently, what are the ways that we can generate domestic resources to sustain the gain. Start the session. I will start by asking the WHO health financing specialist, the authentic Dr. Francis. So what can we do as a country to provide adequate resources for HIV? And Dr. Francis has requested for this presentation to be put up. Can we please, Secretary, can we have the presentation? Okay, the presentation is on. That's not the presentation.
Okay, so while we are waiting for the slide to come, there are a few contexts that we need to establish while we have the issue. Indeed, we know that the Nigeria is, but we do not have that in the expenditure
in
Presentation
HIV.
you gave us, that's not the one of talking
Yeah,
about.
if my slides had come up,
One on the,
so that we take a look at how we have done over the years in terms of where the resources are going to. So if you look at the funding for health in Nigeria, you see that just about 8.6% of the current health expenditure in Nigeria, according to the National Health Account, goes to HIV. And that really is a reduction, because we know that in 2018, we had.
And I came here to ask 3 times. He said he has this already. Are you sure it's not this one that can you come? Tell him it's emergency now. He should run down here.
Just the third highest go down, and this aggregate the funding and expenditure around complicated then if you look at where the
What's the name of the slide? What's the name of the slide?
I don't know the name.
you see that mainly the expenditure is from
They sent one to my mail.
60% of this expenditure is from household, even though we have some of them coming from the donors, coming from government at the 3 levels. It's important for us to also look at the data from NASA.
You have it.
And NASA is showing us that of the various sources, the donors now so here the donors.
I'm on my mail. Let's forward my mail.
One
Yeah, forward my mail.
important point to note for NASA is that it doesn't include human resource funding. It doesn't include human resource funding. National Health Account includes human resources, and that's why you can see it. But I would like to also stress that by thematic area, expenditure is maybe up to 37%. 57, sorry, go to care and treatment, and then if you now come to factors of production, it goes to medical products and this correlates with the national fund going to curative care rather than prevention, where you want it to be. And of course, when you drill down, you also that's medical spending. Now, what are the opportunities that we have? There are a number of opportunities that have shown up, just like my brother had mentioned, because we know that this funding for HIV is expenditure. It's not enough. So, do we have opportunities? We have opportunities in terms of what is going on in Nigeria right now with government ownership and stewardship, the sector-wide approach to investing and financing healthcare in Nigeria, where the global health initiatives, the other development partners, and the private sector are putting monies together to ensure that the hyper-fragmentation in Nigerian health system is reduced, and then we'll have adequate resources to be able to finance the priorities, which includes HIV. Of course, there is the huge private sector in Nigeria, but health insurance provides good opportunities. But just a point on innovative financing approaches, and I close, which for us presents a lot of opportunities either to raise more funding, especially as we have seen that it's inadequate, or perhaps increase value for money. Because if you check where we are putting our money into is mainly care and treatment, which in real economic terms is inefficient.
And then, of course, if you go down, the monies are going to mainly medical goods and supplies, which again is inefficient. So do we need to change the narrative and redirect the funding? It will also boost innovation and finally ensure appropriate transition. And what are these? And I'm just going to mention them and sit down. Perhaps we can have further conversations around them. One is blended finance. The second one is debt for health swap. Of course, we've had this in Nigeria before under the MDGs project, where Paris Club had given Nigeria debt forgiveness. And then part of it was earmarked to finance a lot of health intervention. But we also have what is called social impact bond. And this social impact bond can be called health impact bond, where certain investors put their money together and then use them to buy services, results. And then there is the health trust fund, just like you have at NACA today, and then earmarked funds like the health taxes, and finally, health insurance savings. Thank you.
Thank you very much. Thank you very much, Francis. Alternative Francis. Quite a number of opportunities. Swap, private sector, health insurance, even increasing efficiency in the way we manage the resources available, resource opportunities like highlighted, and then innovative finance. Taking one of these opportunities, let me come to you, Dr. Kofi. Sometimes family has, alongside other partners, have been working with NHIA, NACA, NASCAP for integration of HIV into health insurance. How do you see that? What are the potentials in that in terms of sustainable financing for HIV?
Okay, thank you very much, Yabu, and good afternoon, all. I think I will start on a very optimistic note. I'll say it's possible. I'll also say it's feasible. And then let me digress a little to first of all put in the background. I think the NHIA, the body responsible for expanding health insurance in Nigeria, has really taken a series of reforms aimed at galvanizing how health insurance progresses in the country. Key among these is the deliberate decentralization of health insurance in subnational to the states. As I talk to you today, all the state governments, no state in the country that does not have a state health insurance agency. At this at various levels of development, with some enrollment, some have enrolled their formal sector, some have enrolled their informal sectors. And so this gives the country a very good opportunity to reduce the out-of-pocket expenditure, as mentioned by Dr. Francis. This is one direction. The second direction, I think, is the context. Covering HIV/AIDS patients is possible, as I said, it's very feasible. But there are some key things I want us to narrate on. One is the need for evidence. And I'm happy to say that the SFH and other partners have worked with the NHI and are also still working to do the actuarial modeling to really predict how much it will cost to really provide these kind of services, looking at the prevalence rate of HIV/AIDS in the country, and also looking at our population growth rate and other socioeconomic parameters. So this is one very important variable that we need to consider. The second thing that we need to look at is the issue of this very thorny question of vulnerability. So where do you contextualize a HIV/AIDS patient? The Basic Healthcare Provision Fund is targeted at vulnerable Nigerians, and vulnerability is defined here if you are extremely poor, or if you are pregnant, if you are under 5. So just a lighter note, a permanent secretary who is HIV positive, is he vulnerable, for example? So this question is something that really we need to know. Where do we contextualize the HIV patients, and then in the aspect of vulnerability? The second issue I want to also throw is the state of our primary healthcare services. Because as Dr. Francis mentioned here, what is key is that prevention is key. And we do know that prevention starts from the PHC level. If we miss it at the primary healthcare level, we will just keep on spending on curative and possibly rehabilitative care, and therefore not changing the health indices of the country. So we need to see how do we ensure that social health insurance has a direct effect on the PSC service delivery, and vis-a-vis how does the HIV funding landscape affect the PSC service delivery at that level. So this is one angle I'm trying to bring in. And then the last thing I want to say is that it's, as I actually said, it's very much possible. But what is most needed is this stakeholder participation, stakeholder buy-in, and stakeholder rally around the NHIA to really build up the evidence, support in mobilizing these resources internally, and leveraging on other external sources also I mentioned, and then seeing how we can, within the context of sustainability, gradually cover the HIV/AIDS patient with social health insurance. The key drawback I see here is in the benefit package, because you want to cover a HIV/AIDS patient, you don't just provide treatment for him. The same HIV/AIDS patient can suffer diabetes, can suffer hypertension. So the benefit package has to be broad enough to cover for his opportunistic and other infections. And so as we try to build the evidence, we should also try to see how much does it cost, not only to provide the services that he needs for his own disease, but also actual services that they arise that has implications. So this tends to this moves me to my last point, which is actually the need for stakeholders to rally down the NHIA to see that we work together to drive this expansion. We are happy in the NHIA, we have a new management led by Dr. Kelechi Ohiri, somebody who is extremely very intelligent, and I'm saying this with all sense of modesty, somebody very sharp, who is focused and determined on outcomes. So we can leverage on the reforms going on in the FMOH and in the health sector generally, and in the reforms that is providing in the NHIA to ensure that we provide a very, very sustainable way of financing healthcare for Nigeria. Thank you very much.
Thank you very much. Very important message. Stakeholder buying is key. NACA, NASCAP are on board, NHIA is on board, but we need all of us to rally around and ensure that we provide support and the necessary data that is required for the appropriate costing of the benefit package that can provide comprehensive care, like you said, beyond just the HIV treatment, but also covering other elements that people living with HIV will require healthcare services. At national level, at subnational level, the funding for HIV seems to be better, or rather, the funding for health as a whole at subnational level seems to be better. But still, across subnationals, you also see that while there is enormous resources for health at subnational, HIV doesn't get the required resources to even complement what is available within the state from development partners. Dr. Usman Bashir, you have been Director General of SACA for your first term for 4 years, and then you have returned again as Director General of SACA. What would you say are the opportunities at subnational level for funding HIV?
Thank you very much for having me. My name is Usman Bashir. I'm the second time DG SACA. I think the first and most important aspect is political will and getting the stakeholders buy-in. It's very important because, like I said, my previous term, we didn't get a single kobo released to us as an agency. So we have to look around outside the box, the partners. But currently, because in the previous term, we didn't have an engagement with our governors, meaning that we didn't have one-on-one to sit down
and explain to him the enormity of the problem. So I think the first thing we need to do is to get the buy-in. And I remember during the last tenure of Dr. Sani Aliu, he was able to see the governors forum, and he got their buy-in in getting, I think, 1% of each state allocation to be given to HIV. But I don't know whether the follow-up was not well done or there were some problems. But I think this is an opportunity now for the new DGNACA to also put that as a front burner, follow up on that 1% allocation, I think, something the revenue, so that can help our states to move on. Like I said, subnational, we know, like the first presenter said, we rely mostly on donors. From what I have found out, about 70% of funding is coming from the donors, and this funding is going down. And we need to really, like the first presenter said, we were going to show what needs to be done, because we need to tell our governors what the partners are doing. Meaning that, like in my state, I came in last year, the budget was around 300 million. And I was able to get more than 50% of that budget release. About almost 200 million was released to me in get recurring test kits. I looked at areas of because we didn't have this for 2 years. So, and I knew that was our first priority. And then looking at data, developing our data system, so that at least we can tell the world this is what we have. And then looking at where we can use our data, so that will help us in looking for funds. So I was able to get, I was able to double that, like 500% increase in my budget. 1.9 billion was approved for HIV response. And I did that with collaboration with my partners, meaning that I engage the partners to see where are they supporting, so that we won't put funding there. And then where are they supporting? And I told my governor, this 2 billion you are giving us, there is 8 billion that is being given by partners, meaning that you're only doing a small part of the job. So we need to break up. And then he really understood the enormity of the problem and seeing that. So I think every other state like Lagos, I think Lagos has already gone off grid, like I should say. They have gone off grid, they're the ones running their response. And then another part is technical capacity. Most of the states really, we don't have the capacity, technical capacity to run the program. So we need a lot of improvement, because when I go to my agency, already now I'm doing a mirror workshop. We're assessing the capacity of each and every staff to see what are their strengths, and we're doing like a SWOT analysis, so that we can see where we can build up the capacity so that they can improve. And then also, like I said, we need to also work on that, meaning that HIV response, our SASCAP and SACAS need to work together, because like I said, SASCAP is already under SACA, like it's in Bauchi State and I think Sokoto State. Already we are working together. Then now the SASCAP is in SACA. So the response, the health sector and non-health sector response is being coordinated on that one. That would help against education, will also help in the coordination and mobilization, because the SASCAP resource will come to SACA, and the SACA resource will go to SASCAP. So there's also already a synergy and understanding. So there's no conflict, and we understand our roles, and we are working together, and there's no problems. And then also integration. We need to also, like Rufi said, we need to integrate into other health services. Like in Kano now, already I've gotten the buy-in of my state contributions agency. Already we are part of the HIV, the PLHIVs are under the vulnerable group now. Already we have enrolled almost 2,000 PLHIV into the healthcare, health contributions care scheme using the EP funds. Already almost 2,000, and what we did was we prioritized, we looked at orphans, HIV orphans left. We put them as the first priority. Then children of PLHIVs, then also those with, like we said, those with chronic illnesses, diabetes, hypertension, so that at least that can take care of other, because the funders are no longer taking care of the genetic infection and other chronic illness. So we have also done that. And then, like I said, and then we need to engage our communities, because the communities are where we are, and so we need to tell them what it is, how we need to do. So we need to also develop what we call maybe HIV Health Trust Fund, which will also help the state in getting funding from our business communities private individuals, companies of their theaters, so that they can help in the HIV response. And then, like I said, like now, recently we had our premarital screening law. Last 2 days it was signed by the government. It was only got for 7 years because the community did not understand. So we have to now change our strategy, engage all the various stakeholders, religious bodies, community leaders, and now they've gotten the buy-in, and the law is now being applied. So we need to really engage our community. Then what is our challenge? And I think our major challenge is limited domestic support. Like I said, we must take side of budget and internet revenue. And that's why I think Lagos was able to go up because they have their IDR live and cut up all the service. So I think the state needs to look inward also, and then also this NACA, like I mentioned earlier, the EG needs to follow up on that 1%. And then all of us need to engage the government. And then the other thing is benefits of donors. We need to also press up to tell our workers, so that's major challenge we have in the state, because donors have given people money to do their work. So now they don't do their work because that money is no longer coming. So really it's a challenge on us and my friend, and that's what we're doing, supporting solutions, so that we follow up and make sure that the staff understand that this is their job. The partners that are coming were coming to help them, and now the partners are gone. So we need to also brace up for this and tell our staff that they understand about what. Then what are opportunities? Because we need to look at, even though we have challenges, we need to look at the opportunities. We need some national entities in Nigeria need to actively participate in funding, advocacy, and service delivery. And Nigeria can make significant strides in sector reform by strengthening domestic investment and engaging communities. Thank you very much.
Very much, DG Saka. Quite a number of things, political commitments, a good one, accountability, strengthening public financial management, also very critical for this thing. Dr. Chiduga, you work in Lagos. In terms of the domestic finance for UK.
And thank you very much for that question. So in Lagos, what has been the critical success factor for all the achievements? Again, it has been reiterated over and over. First of all, because COVID. So we have been fortunate over the years to have governors who are invested in the HIV risk. Again, the government for Lagos is a big difference. The SACA is under the government. So it has direct oversight from the chief of staff. And that helps in getting to the CEO of the SACA has direct access to the governor's office, and that really promotes political will. Again, is that we have the technical competence, both from the State Health Insurance Agency as well as the AIDS Control Agency. So over the years, we have been privileged to have very knowledgeable technocrats who have been at the helm of affairs, who are go-getters, backed up by the state strategic plan and wanting to implement that state strategic plan and to reach it. And then again, I think the collaboration between the State Health Insurance Agency and the State Control Agency, especially when it comes to HIV integration. And so Lagos has to go the round of developing an HIV state-specific roadmap for HIV integration, leveraging on the national document of the HIV blueprint for integrating HIV services into State Health Insurance. And then he went further to do a state actual analysis to find out what is the added cost. And while he was talking about PPMC, we had to do that back in 2020. We generated what is the additional risk premium for adding ARV, for adding additional HIV services into the benefit package. And at that point, we had the evidence, but the scheme wasn't that large enough for us to add on things added to HIV services. But it provided evidence for other services that we could add without increasing the premium, which is both a technical decision as well as a political decision. And so it gave us room to add services like client-initiated testing. So prior to that time, what we had in the health insurance benefit package was just provider-initiated testing. But after that actual analysis, we could add client-initiated testing, which speaks to the first 95. That means anyone who is enrolled has access to HIV testing. The doctor doesn't need to request that test. If the client or the enrollee request that test, the person has access to that test. And then we also, the actual analysis also helps us to add what we call a service charge for ARV. So while the conversations on open market access to ARVs is ongoing, the enrollees of PNHIV suffer out-of-pocket expenses for refill. So when they're canceling their medication, they pay a service charge to those facilities. And so what we try to work in, was how do you eliminate that user fee at the point of getting your prescription with refills, and so that we also eliminate that user fee. So those are some of the things that we've been able to do, both policy-wise as well as implementation. Again, was to, as the commercial we talked about, to make it community-led. And so therefore has really provided leadership in Lagos. They have been at the forefront. Everyone has this strong relationship with the State Health Insurance Agency, the Public Awareness and Advocacy Committee of the State Health Insurance Agency. So they're able to speak. They have a seat at the table, for speaking up for the populations that they represent. And then that has led to the enrollment of persons living with HIV. So backed by state strategic plan, backed by the state-specific roadmap for HIV integration, we are now enrolling vulnerable peer HIV under the State Health Insurance, again with the support of SACA and the State Health Insurance Agency. These persons are vulnerable peer HIV who have access not just to HIV services, but to the border-based services. Again, because peer HIVs are living longer, they're having non-communicable diseases, which they suffer out of pocket for because that's not covered by any donor-funded program. So how do we improve their quality of life, grant them access to a broader range of non-HIV services, so that they can have more money in their pocket and they don't suffer out of pocket expenses, attention, activities, and they can actually live longer and improve the quality of life. Thank you.
Thank you very much. A combination of political commitments, evidence generation,
Engagement. Stakeholder engagement, stakeholder inclusion, particularly private sector. So when we're talking about stakeholders, I've heard a lot of very smart and intelligent conversations. What I've not heard is how private sector, the most optimal way to engage and attract private sector funding. And what I will just put to you, everyone said here today, is to imagine that international partners wake up tomorrow morning and stop funding HIV. Who are our next likely funders besides the government that are proven over and over again that the disease burden is not entirely priority? It's likely to be the private sector. And so when we're talking about stakeholdership, we're talking about you understanding who your stakeholders are. HIV is an epidemic. Private sector, like any other critical group in the society, is a stakeholder. Imagine what happened with COVID, and imagine how private sector goes up beyond imagination to be able to address the situation. So what I would encourage is a lot of awareness within the private sector community in such a way that they become also advocates, they become also drivers of this conversation, and they understand what is that is needed. About stakeholdership is also that there is a business case why the international community is still funding this burden. It is for us to be able to also have out a business case for the private sector to also rise to that obligation. The business case for the international community is not, it's not something that is really discussed. I've been noticed, I've been asking questions. And so there's a reason why they do it. They don't do it, it's not just charity. It's something, somewhere behind the scene. It makes a bit of business sense to them. How will it make sense for your critical stakeholders to be involved in addressing this disease burden? It's what I think we should also ask for all of the hard work and all of the very interesting dynamics of HIV situation in our country.
Thank you very much. That's another perspective to it.
So before I come to the audience,
somebody else, then we go back now. Mr. Chairman.
thank you for your comment and your contribution to this. So something that is key is that we are going to have a presentation from Dr. Jeku, who is the CEO, of the HIV Trust Fund of Nigeria. If you take that presentation shortly, please let's have it from. Then while we are discussing that, however, referring to that, we realize that the question is, each of HIV finance, does it have a cost? I think from the spot of those so far that it has a cost. Now, how do you cover the cost? That should be what we are able to access. And if you look at it critically, it's either be through government, direct, through insurance, through private system, or even individual pocket or out of pocket things. But in terms of donor, we've not said it today that definitely they won't be here forever. And then the government said they may be a business model. So why can't the country also develop a business model for HIV financing, which is similar to what the Coordinating Minister of Health is pushing and is driving, which is unlocking the value chain. A system where you build your economy on the needs and services you have to offer the people, including production of materials, consumable tests, kits, ARV. It tends to give you profit into your system. It can also use to, of course, finance the HIV program. So while we think, okay, I think it's set now. So
political will, very, very important. And there was also a mention around, I think it was Dr. Rashid also mentioned the fact that we have instances where people who are supposed to do their work either refuse to do so because the donor agencies are no longer providing the funding. So, having said this, though, let me go into my presentation. So, it's the future of HIV funding in Nigeria. What the trust fund has but I can talking about. And entrepreneurship cuts across the private sector, leadership, the various tiers of the private sector, the public sector, both on the federal level and the subnational level, and then the private sector. Next slide, please. We've had this epidemic since 1985. In my presentation, I will talk about the epidemic in two phases. From 1985 to the in 2001, when for the first time we said, okay, you know what, all the countries in Africa, let's dedicate 15% of our budget to address this scourge. And then, of course, we also had a situation where with the arrival of antiretroviral therapy, and suddenly For the first time, HIV was not as scary as it used to be before. And it took a backseat. We no longer had a burning platform moment the way we had with COVID-19. The reality that fear is a tool that unlocks the pockets of the average person. When we have people dropping, these people we knew dying of HIV, people were willing to step forward and take action. So today, even in our deposit mobilization, sometimes we go to people in the private sector and we are pitching the trust fund to them, and you know the response we get from them. Do we still have a HIV problem in Nigeria? Consistently. Yeah. What it then means is that everybody who has been attending this program since yesterday and who are the experts in this state, I'm not talking to the right people. We're not talking to the people who have the capacity to fund our domestic response. And do you know why we're not doing that? Because we have donor international agencies that have taken the front seat and have been doing it for a while. So the funding approach we've had from 2001 to date has worked perfectly, but it's not sufficient to drive sustainability. That funding model was an emerging funding drive. It's nothing. And why are we here? The only reason why we're here is that some people funded this, and I mean, when DACA was pushing me to fund, even from the private sector, it was difficult to even contribute. But we know for sure that there are several other needs that are talking at our traditional donor partners and are distracting them. And we know for sure that this day will come, not today, maybe not tomorrow, maybe not next year. This day will come when the priorities will change. And then what? And then what? Next slide, please. Next slide. Chairman, in my instance, you can't talk too much about time because without this one, there's nothing going on. But I understand you. So one of the things I believe that has to happen the CEO of PISHA, Private Sector Health Alliance, was supposed to be here today to talk about the work they are doing in strengthening the private health care centers across the world, across Nigeria. So these fundings have to come in place either from the state level or the federal level to strengthen our primary healthcare system. Significant donor funding that is coming into Nigeria to fund our national HIV response. Most of it is being spent in Washington and Geneva. So we need some kind of farmer independence. We need investment in the production of local consumables. We need to invest in that entirety of the value chain so that the business community will see a need to invest in this. And because of time, I'll just cut this short. Finally, and in summary, I will say that all of us need to take the HIV Trust Fund of Nigeria as ours. It's not a private sector owned establishment. It is the one of the first steps to the new funding model that will drive our national HIV response the day our donor agencies say, you know what, guys, time up, we are done. Thank you.
Thank you. So he has brought up a couple of thoughtful things that we have to think about to address. But I think we should throw it open for those that have or comments. Let's have 3.
Because I use my yes,
Okay, thank you so much. I think mine is more of a commendation to the group, the team. This is the future, actually, just like JP said. JP, thank you for the presentation. It's more of the future. I was a bit more concerned about the last comment JP made, because really this is the future for health financing. In fact, every other interventions that we probably may be doing in Nigeria. So I just wanted to ask him that, what do you think we can do? Because I sat here in my own corner and I was thinking, okay, yes, when you asked the question, have we contributed? And I thought, oh, I haven't contributed. So I would encourage you to probably run a big campaign, maybe create that awareness where people know that there's a pocket of somewhere that people could be donating to. And then also, while pushing that out, you must let people know that there's a strong accountability mechanism. Because of course, you know the context within trust. So thank you very much. And thank you, panelists.
Thank you very much. Conversation with them. I think beyond that campaign is to see the case is an ugly case, and we're not calling it an ugly. We're sugarcoating it. So the society is not aware.
It's about my
But we thought we had friends, we had relatives who died of HIV/AIDS. To let everyone in the society who are critical stakeholders understand that this can come back if we don't run around and if we don't address it.
Okay, thank you very much. It's a quick one. I wanted to find out if the funding has it been operationalized? You know, are there challenges? You know,
So that's the HIV Trust Fund. Okay, thank you. Yeah. Okay.
Thank you very much, sir.
Okay, so thank you very much, sir. So my question now is, number one, I'm like the fact that we are looking into as an health insurance space, but the challenge, if the share can actually help us to provide maybe some kind of analysis to that, because we are looking at health insurance scheme for the HIV response. So now, looking at some of the states, they are owing salary for civil servants. And now, like, we are pushing insurance claims into the state. Yeah, all the states have adopted that. Yeah, there's no for health insurance claims across the states. So in the long run, if the states if the state cannot able to make funds available to support the insurance schemes, what will happen to people living with HIV is that we've already enrolled on this scheme. That is number one. So
Thank you so much. Mine is just a comment around what the HIV Trust Fund have just said. The panel has really shown that one of the gateways to actually improve the response or accelerate the response is around health insurance. And we haven't had the model, maybe the HIV Trust Fund is doing, because we had the PSCPS as the gateway that have covered a bit vulnerable group. We had the also NPSCD and others. What really is the trust fund really doing? Ensuring that there's harmonization between the subnational, the national, and also other responses, especially in health insurance, the social insurance side, which is more sustainable to
Please go ahead. They are still talking. We'll talk to tomorrow. Like 5 people carry their hands up.
Syphilis testing currently going on outside in the White Bank. Thank you. And second announcement for the chairman of the scientific committee. He has asked that we close all sessions for 15 minutes to allow participants and delegates have their lunch. Thank you very much.
Okay.
Exactly. Okay. You still muted, Abby?
No, I didn't
Take
even.
an amazing.
Thank you very much. So let me just turn to Dr. Krupi to respond to the questions on health insurance.
Okay, thank you very much, Dayabu. And for the speaker, I think this will not be the time for me to give you a detailed lecture of how insurance works. But the clear pathway is that somebody has to contribute, and there are packages that a person living with HIV that wants to enroll into health insurance will pay for, and these are costed packages. And once he buys into that, the sustainability is on how much the contributions come in, how regular they come in, and also the size of the pool and the rest. So this is not the time for me to really give you, but I just want you to know that with health insurance, there are mechanisms to ensure that those pools of money also have reinsurance, right? And that so somebody that is bearing the risk also has another person that is bearing the risk of that risk bearer. So there are mechanisms to ensure the sustainability and the viability of that fund. You know, the NHIA has existed for the past 15 years, and we have never had 1 month of inability to pay for services. And none of the state social health insurance agencies so far has not been able to say that they have not paid for services, because these are things that are well planned. Yeah, so that's just it. The second question, I just wanted to also ask, just a comment. Really, and this has to do with the trust fund. And it's really needs to, I want to just
You not invited your own colleague. Oh.
What's that presentation?
No, you invited your colleague. I gave her food. That me, I'm sitting down here with you. I've been walking. It's not like, okay. You were even basically offering it to her. You didn't offer it to me. I was not that hesitant to put my hand inside. I should clap for you. Gave her water, gave her everything. Like, did he really do that? Okay, that we were something. But the fact that we are working, if me and that here in this control room, it's like giving another person attention and preference. I'm like, okay, let me just try and understand. And I was lamenting. But yes, I was lamenting now. I was hungry. I wanted to go and eat in my own. We have our own food, but I couldn't go. By 3, they rounded off finished food because they were busy assembling to. If not, I would have gone even if it's 3 o'clock. And he didn't even notice me. Yes. But now you understand what I'm saying. I'm like, okay, maybe she's his girlfriend. That's why he's even doing all this. I don't know. Which one? Which one is that one?
Do I know how to come?
I don't know.
Yeah,
don't mention myself, but someone else. I know the only person I mention on left one. I know I have just I don't mention anybody, including myself. You said something about it. Documentation about it. Always missing.
No, she has always been.
But she's missing. Yeah. NHS. So I'm not a competitor, so I don't know why you think I can come and be mentioned. I'm not even welcome. No. We keep moving around. Meet the secular.
Please, can we all sit so that we can start this? Hello. Can we all settle down so that we can start this session? Okay, thank you very much.
Director in the Education Support Services Unit, Mrs. Njideka Obukwe. Please join me welcoming her. Mrs. Njideka, you are welcome. Please clap for her. Please clap for her. From the Federal Ministry of Health, we have the Deputy Director from Gashe Unit, Dr. Silvanos Wele. You are very much welcome, sir. Don't forget that we are talking about multi-sectoral approach, and we have education, we have health. Also, this evening, joining us as one of the panelists is Mrs. Oyebukola Tomori Adeleye. She works with young people at the United Nations, precisely UNESCO. Welcome, Mrs. Oyebukola Tomori Adeleye. And also, we'll be looking at the issue of comprehensive sexuality education within the HIV integration. And I have here Dr. Babatunde Adelekun from the UNFPA. Dr. Adelekun, you are welcome. Also talking to that is Dr. Esther Shome, also from UNFPA in Lagos. You are welcome, Dr. Shome. I promise you will try to manage the time very well. Thank you. You are all very much welcome. I will ask all, just a round of questions, and then we can open the floor for questions or contributions from the audience. Let's start with you, Mrs. Njideka. Of course, we've heard about WCA commitment and so on. We would like to know, what is this WCA commitment? What is it about? And what is the Ministry of Education? What is your involvement in this? If we are looking at it from the multi-sectoral dimension, what has the Ministry of Education been doing on this, and who are the other people that are involved in this? Yes.
Yes. Thank you very much. Good evening, everybody. As
Can put that up. Sorry, I left someone out. Thank you so much for reminding me. We have the youth reference for the WCA in Nigeria. Chidima, I'm so sorry for leaving you. Please, can you kindly join us over here? She is the youth reference for the West and Central Africa Ministerial Commitment. Please give her a round of applause. I'm so sorry for leaving you her. We need the young people. It's because of them. Yes, back to you.
thank you. Yeah, as we all know, WCA is the West and Central Africa. And when we talk WCA commitment, we are talking about the commitment that was endorsed to by the Ministers of Health and Education, Nigeria, with other ministers of the West and Central Africa countries at Congo Brazzaville in April 2023. And in that commitment, these two ministers, on behalf of Nigeria and other West and Central African countries ministers, also endorsed to a commitment to an educated, healthy, and thriving adolescent and young people. And in that commitment, they agreed to commit to an adolescent and young people that are provided with every enabling environment, skills, information that is needed for them to grow up, to be healthy, to thrive in our society. And then after these commitments were endorsed to, the ministers were asked to now go to their different countries and have these commitments, domesticated so that the countries can now fly with it. And then when they came back, we all came together and had domesticated this commitment to our own peculiarity. And then from the 9 targets that was committed to, we came up with a 6 targets for our country. And then after that, we started looking at what are the modalities to have these commitments, practicalized. How do we domesticate it? Then we now have a work plan. We came up with a work plan, something that will be workable for our environment. And then, like you all heard, this is a multisectoral thing. It's not something that only education is doing. We heard that it was the Minister for Education and the Health that endorsed to this. And then back home, we have other sectors that will have to come on board for this to be practicable. We have the Ministry of Women Affairs, Youth, we have Budget and National Planning, we have Ministry of Humanitarian Affairs, and all of them coming together to draw up this work plan and see to its workability. And for education, we are interested in ensuring that everybody come on board to make this work plan actualize it as a country. Thank you.
Thank you very much for that. So let me go to the Federal Ministry of Health. So what has the Federal Ministry of Health, how have you been involved in this WCA thing that she has told us about? And then generally, where are we as a country on the WCA commitment? Yes.
Okay, thank you very much. Like the previous speaker said, Federal Ministry of Health has been involved from the word go. because starting from the high level political commitment, our Honorable Minister of State for Health was in Congo, Brazzaville, okay, for that commitment. He didn't go alone. In his entourage was also the former Honorable Minister of Health, Professor Isaac Olorunso Adewole. Okay, so after that, the other aspect that the other area that our Ministry of Health was involved is in the launch of the O3 program at Kentele in Tanzania. Okay, for those that may not have heard, O3 is a program that letter O and then 3, and it stands for, the first O stands for our rights, second O, our lives, and then the third O, our future. So it's a program that the country is using to drive the commitment, the education for health and well-being, commitment on education for health and well-being of adolescents and young persons. When the delegation came back from Congo and Tanzania, we had a first advocacy and strategic planning meeting. Federal Ministry of Health was represented at that planning meeting. At that first planning meeting, education developed their plan, while Federal Ministry of Health developed, we also developed our own plan. At a later date, we had to come together to harmonize the two plans. Federal Ministry of Health was also represented. Then, even in the finalization of the plan itself, the West, after the harmonization, the West and Central Africa Commitment Plan, we were there at the UN House. And then at the launch of the advocacy kits, where we have messages on this plan, during the event, we invited, I think UNESCO anchored the program. And during that event, traditional rulers from almost all the 6 geopolitical zones, including commissioners of health and education from Osun, Benue, and other states were there. Federal Ministry of Health was also there. So let me stop here for now. Thank you.
Thank you very much. The other part that we did not talk to, I said, as a country, where are we on the? I don't know if the next speaker will want to talk to that. Though I'd love to ask you, Mrs. Tomori Adeleye, he made mention of 103 project. What is the 03 project? What is it about? And how has this impacted the education sector in Nigeria?
Okay, thank you so much. I almost was put on the spot because I didn't see the question coming. But thank you. Basically, the O3 project really sits to answer the question of, do we continue to ignore the times, or do we continue to pretend that our young people do not have ASRH issues? And in addressing that, the program, it's actually an initiative in the West and Central Africa, looks at key areas. One is policy engagement, advocacy and policy engagement. It also looks at youth engagement. It also looks at, and a very major pillar of it also looks at, what's this now? Data management issues, and quite a number of others. We also basically focus on empowering curriculum. Now, primarily, the program looks at creating enabling environment for young people to have culturally sensitive information and approaches that can cause behavior change. So in Nigeria, currently we're in 13 states. Before now, it was implemented in about 10 states in Nigeria. But early this year, states in Nigeria. Oh, you want me to mention the states? Okay, so from the east, let me start from the east because I think my sisters in front are from the east, right? So let me start from the east. So in the east, we have Anambra, we have, no, sorry, we have Enugu, we have Ebonyi, we have Imo. In the south, we have Cross River. Okay, that's where you're from. Then we have also Abia in the east, and then we in the north we have Kaduna, we have Taraba, we have Benue, we have Gombe, we have where else? Where am I missing now? Taraba, Gombe, Benue, and then in the west we have Lagos. Yes, I've mentioned Nasarawa. Sorry. In the west, we have Lagos, and in this phase, we're moving to Osun State. So we have a plan to move to additional about 7 additional states more before the end of the year. And one of the things for us, a key indication to move into a state is the political will of the government of those states. For instance, in the last 3 states we moved into, we had the office of the executive governor actually request that they needed support for in-school health programs within those states. And based on that, we were able to move to that. One very integral part of the program that I would like to highlight is the fact that within the education sector, we're working with the EMIS, Education Management Information System, to ensure that in the annual school census tools, they integrate health indicators. So that means that necessarily within the schools, we're able to get data around issues that affect ASRH for young people in schools. And that was a tremendous direction from the WCA commitment. Thank you so much, and over.
Thank you very much, Mrs. Tomori Adele. Let me go to Dr. Shumeku. We know that UNFP has done a lot on comprehensive sexuality education, especially among our young people that are outside the school system, they're out of school. Let me request that you tell us the place of comprehensive sexuality education in HIV programming. What is the place of sexuality education in HIV integration? So over to you.
Thank you very much. As we know, the HIV program in AYP investment case for Nigeria has as its objectives 3 main objectives. One, to increase comprehensive knowledge on HIV. Second is to increase access to condoms. And the third is actually also to prevent any other to increase uptake of condom and to increase HIV testing. So those are the 3 main objectives, and it's from that angle of provision of comprehensive knowledge on HIV that we bring in the comprehensive sexuality education curriculum. The comprehensive sexuality education curriculum that we have is actually aligned to the ITGCSE agenda, and the curriculum which we developed has 6 modules, of which one of the modules has HIV extensively explained in it and talks about not only the mode, it also talks about the various myths and conceptions about HIV. It also provides accurate knowledge about how you can protect yourself as a young person out of school from having HIV. And okay. Beyond just having the curriculum, what we have gone ahead to do as UNFPA is actually to build capacity of the Association of Positive Young Persons, the Secretariat, and also the support group leads in the ART Center. So we built their capacity using this curriculum that we have developed, and what they now do is to go ahead. The curriculum is actually, it's a 9-month curriculum. So for every support group meeting they have, they now use that to engage with the young persons who have HIV. And then one layer we've added, or two layers we added onto it, is that we also provided them with condoms, because we know many of them go into relationship, they are not able to go to facilities to request for condom because they can't even talk about their status. So we added that layer of not just only them providing information on sexuality, but also that they're able to distribute condoms, and we're able to get data back from them. Another layer which we added to it is to build capacity of youth-led organizations who work with young people who take drugs, young people who sell sex, young people with disability, to be able to use this curriculum to reach them and provide them also with condom. Thank you.
Thank you very much for that. And one of the things that you mentioned was the challenge around being able to openly demand for condom. I would like Dr. Babak to talk to this. What are some of the challenges based on your experience on the field? Challenges around working on comprehensive sexuality education among young people in Nigeria, and how have we been mitigating this?
Okay, thank you, moderator. There are a lot of challenges with comprehensive sexuality education because of the social, cultural, and gender norms that are quite enshrined into the polity. A lot of people are not comfortable with mentioning issues around sexuality in the country. You know, the kind of country that we have in. And so because of that, there seems to be some, form of opposition to that word sexuality. And what has been done at the national level is to, shift emphasis from that sexuality to make it what we call the family life HIV health education curriculum. But in some other states that we work in, like for instance in Lagos, because of the concurrent issue, they said they wanted it to be comprehensive sexuality education because they want their young ones to be able to really understand the issues around these things that like we are talking about. The other thing I think is also the fact that we don't have the capacity of teachers and instructors. They don't have the right methodology and approach for them to be able to deliver comprehensive sexuality education. And you'll recall that at the UN, we have what we call a division of labor. For instance, in terms of comprehensive sexuality education, this is a program intervention that is done by UNESCO and UNFPA. And UNESCO is responsible for the in-school variants of that particular intervention, while UNFPA is responsible also of those issues. Also parents religious have asked to make young people have the knowledge and information that they need for them to be able to be self-aware of themselves and their sexuality, and then do the right things. And what we have also done is for us to also build another component to this, when we also engage with parents in the community, engage with religious and community leaders, so that they understand exactly what we are doing. The last one is about the challenge about condom that you raised, because the issue is beyond knowledge, beyond information. That needs to be translated into positive behavioral outcomes. And for us, we took this as very, very important. And the aim is for us to ensure that adolescents and young people primarily abstain from sex as much as possible. But we know that data is showing that at least 40 or so percent of them also engage in unprotected sex. So for those people who are trying to continue to engage them, we also make sure that they also ensure they have sex that is protected, because it will help us to address teenage pregnancy, help us to address HIV, help us to avoid STI, and several other things that can occur. And so what we have done is to ensure that we link up the CSC component with the health component, so that the peer educators, the people living with HIV, can also liaise with the health system to be able to get condoms, and then do what we call community sensitization and awareness to be able to address those issues. Our aim is to make sure that young people have the self-efficacy, they have the confidence to demand for condom when they need that, because we really need to say the fact. It's not everybody that will abstain. For those who are not abstaining, please make sure you play it safely. And through various means, through outreaches, through sensitization, we've been able to let people understand
delighted to know that a lot of activities they are going on out there on the field. You talked about FLHE for out of school young people. I'm so glad to know that. I don't know, do we have FLHE for in school young people? Your O3 project, does it have anything to do with FLHE? If we are doing it for out of school, do we do anything for those that are in school?
Okay, great. Thank you so much, moderator. And thank you, Dr. Baba, for creating that delineation. So yes, the O3 initiative is very focused on the e-school response, particularly just like Baba said, because we need to strengthen systems to be able to empower young people to take responsible decisions and to be able to actually take charge of their future. And so in order to be able to align that, some of the things, like I'd initially mentioned, there's paucity of funds in the country, but most of the approach that the O3 uses is a catalytic approach. For instance, we look at how well can we create an enabling environment to make sure that within the school structure, there are policies that can enable a young person have access to information, have access to ASRH services. Another one, for instance, just last year, with the support of many other partners, we supported the Federal Ministry of Education and the Ministry of Health to get the policy on the HIV policy reviewed. And it was assented to by the Honorable Minister of Education last year. Another thing is teachers. How do we build their capacity to be able to respond and improve the pedagogy of children within schools? And so one of the things we've done, another initiative that program is actually throwing to light in collaboration with UNFPA, is also that we have a CSC platform, Family Life and HIV Education platform, that is currently going to go live in about a month or two, where we're going to be building capacities. There are live scenarios where young people can have access to information and strengthen teachers' capacity to also be able to, respond to the needs of young people within the classrooms. Also, a lot of results, as I've mentioned. I know we don't have so much time, but one of the ones I'd like to mention is that the O3 program also looks at gender-based violence, safe school initiatives. How do we ensure that policies for safe school is there? How do we also ensure that there are linkages between schools and health facilities for young people that are sexually abused and all of that? And then lastly is also to build evidences for improving program outcomes. I liked the fact that Dr. Somfon mentioned how well the Family Life and HIV Education leverages on the international technical guidance on sexuality education. So, sorry. Okay. Yes. So, and I know we are all quite aware of FLHE in Nigeria. So the FLHE curriculum is very, very rich. And as time is moving on, we're trying to see how to continue to enrich it. Thank you so much. And over.
Thank you very much. And then I will ask our last panelist, like I promised, we are going to manage the time very well. Chima, is there any role? Okay, good. Questions are already coming. After the last panelist, then we take questions. What is the role of our young people on the WCA commitment? What have we been doing as young people on this? It would be nice to know. Yes, over to you.
Thank you, Mr. Oladeji.
Sorry, if you have any question, you can kindly write and send to us so that we can manage the time well with that.
Okay, thank you. Hi, okay. I see there are a lot of young people in the room, and it's good to use this as an opportunity to figure out if any of us know what the WCA commitment is about. Because I recall when I came for this conference and I asked about two young people at the youth conference, and they were like, "What's the WCA commitment?" And I had to tell them about it and then tell them to go online to see what it's about. So it's about adolescents and young people. And my involvement with the WCA commitment started in September 2022 when they were trying to figure out what are the challenges that the young people are facing, and let us use that as an opportunity to tell our stories and advocate, because this is about us. And we also have to be key players in the whole implementation. And that was what I found fascinating, because we had the Education Saves Lives campaign, which the phase one began in September 2022. I had the opportunity to share my story of surviving gender-based violence from Nigeria. There were young people from Togo, from Cameroon, talking about their experiences living with HIV, having unwanted pregnancies, and different challenges that young people face in West and Central Africa. And that was like the first point of call to see these are the challenges that young people are facing. How can we now advocate for this group of young people in West and Central Africa? And that led up to the endorsement, where I also had the opportunity to share my story in front of multiple stakeholders, ministers of health and education, and there was they endorsed the commitment in all countries in West and Central Africa. And coming back to Nigeria, to be honest, I thought that was going to be the end of it. But apparently, this is a real commitment that every country is implementing. And one of the things I found out was that young people have become partners, because this is going to be like my fourth meeting, having opportunity to talk about this and advocate for the WCA commitment. Young people are becoming partners who are taking our seats in these spaces. It's not just like they are working for us and we have challenges, and those people that are key decision makers are trying to solve our problems. We are now being part of those spaces and ensuring that the implementation happens and these kind of things. And there's something also that we are doing when it comes to accountability. So one thing I noticed also was that after the first phase of the Education Save Lives campaign, we had to create a youth community where young advocates in West and Central Africa are part of that community, the regional youth community, and also the national youth community, where we have Equipop, who is like one of the technical partners, helping us build our capacity. I have taken courses with them, UNESCO, UNFPA, talking about comprehensive sexuality education. How can we advocate? How can we also, be like town criers in ensuring that the key decision makers and key role players are actually playing their roles? So that's one of the major things I've realized, that they are building our capacity to ensure that we understand what advocacy is, and we ensure that the people who have made this commitment are implementing and ensuring that they are accountable to this commitment, and it's not just going to be something that is said with words, but it's also backed up with their action. So currently we are now, tomorrow we're going to be beginning the phase 3 of the Education Saves Life campaign, to also create awareness that young people and all stakeholders involved know what the WCA commitment is and can also follow through with the whole plan and process. Thank you.
Thank you very much, Chidima. Thank you very much. We are coming to the end. I would like to take questions from you, but kindly write the questions and then send. We have some here already. One is talking about, I think this is for Dr. Abatunde. One is talking about social accountability of adolescents to demand for their rights, investment, and education. Would you want to, what do you want to tell us about this? Do you think there is are there framework? Thank you. Are there framework for social accountability of adolescents to demand for their rights and investment in education? Yes.
Thank you so much for that question. It's very, very clear that there's an accountability framework that we have all around, but it seems some people do not have the information and understand the process for doing that. And recall that my colleague Dr. Shomerfu talked about the fact that there was a business case investment that we have done for HIV programming for young people in Nigeria, and that shows clearly all the things that we're supposed to do. So there's the individual, which is the adolescent, there's the government, and there's the community. So when everyone is able to do what they're supposed to do, then we'll get a lot of traction. So for adolescents, it is clear, that if adolescents are not educated, they don't have information, they don't have knowledge, they have a high tendency of, engaging in negative, behavioral things that might lead to pregnancy, HIV, STI. Science has shown, and we have also demonstrated that even in Lagos, that CAC knowledgeable adolescents compared to CAC or FLHE naive adolescents are able to understand what is HIV. They're able to understand what is prevention of maternal to child transmission, understand condom use, and all those kind of things. So there's sufficient evidence to say that when adolescents have the right information, there's a high tendency that they will elaborate positive health behaviors and attitudes and values that will ensure, for instance, for this HIV, we bring down, the prevalence and incidence of HIV within the country. So the social accountability framework just talks about adolescents understanding the need for them to demand that the right investment is made in their education, the right investment is made in the health system, and that they allow the institution to give them necessary information for them to be able to make their informed choice. And we see clearly, even from anthropology studies, that adolescents are energetic, they are young people, they are dynamic, they want to try to test out something, they're adventurous. But when you deliberately refuse to give them the right information, then there's a tendency that they will seek those information somewhere. So we're saying we must come to a point where adolescents, and that's why we're using the peer-to-peer approach in the in-school environment, in the out-school environment, in your community. Try to ensure that you converse with your peers and let them have the right information. But secondly, because we have instrument policies and guidelines in place, HIV investor business case for HIV programming for adolescents and young people, we have the school health policy, we have the HA policy for school, several other things. Use that to demand that the right investment is made in your education and in your health, and that the government and all structures begin to ensure that they program for adolescents and young people within this HIV response. Because when we do that, we ensure that these adolescents and young people become healthy and become adults and navigate through that adulthood process to have the capacity, and they're empowered to contribute their quota to the development of the country.
Thank you very much. I have a tons of questions here. Let me start with the FLHE curriculum. A lot of questions on this, and we want to throw this to the Federal Ministry of Education, the Assistant Director from the Federal Ministry of Education, and I'm sure the colleague from UNESCO working with you will be able to support you on this. Number one, why is the FLHE curriculum and its content not widely disseminated? Why is it not widely disseminated? Then the next question, I think I should just read all these education questions because there are about 4 questions in one. And then secondly, the person say, how can the issue of pushback from rollout of FLHE in schools by PTA be addressed? How can we address the issue of pushback on FLHE in school? Number 3, can advocacy be done to state ministries of health to ensure FLHE is integrated in education? Can advocacy, Dr. Weller, I think you should take this, please just note it. Can advocacy be done to ministry of health to ensure FLHE is integrated in education? Number 4, we need to scale up FLHE for both in school and out of school as national level. This is we want to react to this also, and Dr. Abatunde, you may want to react to that. There is a need to standardize in school and out of school youth HIV programs being rolled out by IPs to get the needed impact at subnational levels. There is a need to standardize in school and out of school youth HIV programs being rolled out by IPs to get the needed impact at subnational levels. This is more of a comment. So, Ms. Injika, let's start with you.
Thank you. If I understand your question, you asked first, why is FLHE curriculum not widely disseminated? To understand that FLHE is a nomenclature. It is not a teaching subject. And then we have topics, SRH topics that FLHE cover. So we are talking about how the coverage of FLHE, is it enough? Has the topics FLHE covered, does it cover enough of SRH issues for young people? And then we can say no. We know that FLH is evolving. We are talking about, there are emerging issues that were not covered in the topics, and then we are looking at how we bring in these issues. And that is why for us in education, we are also looking at other strategies of addressing SRH issues, because there are three major approaches to FLHE. We have the classroom teaching, we have the peer education, we have assembly talk. It is through these approaches that FLHE topics are covered. At the assembly, we have topics being discussed generally so that every student is informed. And then we're looking at also bringing in these SRH issues into assembly topics, to issues addressed at assembly, so that students are also empowered and given right information. So FLHE is not something that is taught only in the class. There are also extracurricular ways of disseminating FLHE information. So it's not about being widely spread, disseminated. It's about being comprehensive enough. And it is that being comprehensive that we are addressing and ensuring that FLHE becomes more encompassing, addressing most SRH issues that are really key in the lives of a young person. And we are still working on that. And then it is ignorance that make parents to push back when it comes to topics or FLHE topics. They will say, don't discuss this one, don't tell children about this one. And that is why we're beginning to introduce sessions with PTA at the beginning of every term, so that the capacity of principals are built to ensure that schools have sessions with parents where SRH issues are discussed, and parents are made to be aware of the need for children to have these informations given to them, so that their capacity is built to, thrive as young persons. Thank you.
So thank you, moderator. So just like she mentioned, FLHE is integrated into the school education curriculum. So what that simply means is that you find it within course subjects within the education system, like basic education, social studies, and some other things like that. So if a teacher is teaching basic studies, that person will be teaching FLHE. But one of the things we try to do within the UN system and with other developmental partners is that we try to see how to strengthen the capacity of the teachers to be able to deliver those skills that can cause behavior change within those subjects. So if a teacher is teaching basic studies now, you expect that that teacher may not be able to really talk about body images, like how it will help a young person to understand our body. But what we now do is to support and strengthen the capacity of the teachers to be able to do that. So, but we still need, a lot still needs to be done. And that's why we're saying we need to employ more catalytic approaches And just like I mentioned initially, that's why UNFPA and UNESCO had this conversation last year. And we tried to look at how to engage more on the digital space. And in about a month's time, we will be launching that toolkit that we expect that will help us reach more teachers. Another catalytic approach that is being used is through the National Colleges of Education. What's that? NCCE. What's it? National Commission for Colleges of Education. And so that commission actually manages teachers that are still preparing to be teachers. So what that means is that while they're in school being trained as teachers, they target them through their GSC courses, and they ensure that they build their capacity on some of those reproductive health issues so that when they get out there into the schools, they are empowered to be able to deliver. So currently, we're also supporting initiatives to ensure that within that system, we are able to push, support, and build capacities of teachers. So just to mention the pushback, we're changing from the narrative of being reactive to pushback. We're now saying that let's be proactive. And that was why sometime last month or 2 months ago, we engaged religious leaders, some of the UN organizations. I think UNICEF is here, WHO, UNFPA, and UNESCO. We all came together and engaged core religious leaders in the country to develop a toolkit and to say that how do we begin to respond before we have opposition? What are the things that we need to put in place to ensure that before opposition comes, we're able to address it and ensure that there's an enabling environment. People understand what we say when we're talking about ASRH issues. People understand what we're saying when we say that a 16-year-old girl that does not have access to adequate information can be a victim of unplanned pregnancy or whichever unintended pregnancies. Yes, I was trying to look. There are so many concepts these days that it takes a lot to be able to catch up with the changes. But yes, so these are the conversations we're having. That how do these religious leaders also understand that when a girl is sexually assaulted or a boy is raped, he shouldn't be silent. Religious leaders and cultural leaders need to start the process to ensure that this person gets justice and he or she also has access to psychosocial support. So like I said, we're being proactive now. It's not business as usual because the narrative really needs to change. Now, in terms of standardization, it's a bit complex to standardize within the education sector because education is on the concurrent list. And so what the federal can really do is to create a standard and say, okay, this is what it should look like. But states have the prerogative to say we will choose this and we will not choose that. I also wanted to mention on the issue of the curriculum review. We've gone a long way. In 2022, there was a step down, just like she mentioned initially. The FLHE curriculum that should go into the schools was reviewed with some emerging health issues. And then it was stepped down by the minister. But the conversations we're having now, just like I said, in order to be able to be proactive, is that currently they're also doing a new review. They're reviewing that curriculum. And there's no noise about this. It's just saying that the FLHE is not in isolation. Those information will go into the textbooks and it will be taught within the classroom. So thank you very much. I could go on and on and on. Thank you, but let me not go.
Okay, thank you very much for that. I think that's enough for that question because we have a lot of them here. Let me ask this question, Dr. Wella. What system is put in place to strengthen more synergy between health sector and education sector in terms of school health services?
Okay, thank you very much. My name is Dr. Wele, not Wella. Dr. Silvanus Wele. Okay, that's just on the flip side. Well, I can say that more than ever before, there is really a strong system, strong momentum to strengthen the collaboration between education, and health. And it is at this juncture I want to appreciate on behalf of the Federal Ministry of Health. First, UNESCO and UNFPA. Okay. Okay, so and they have done this not just in Nigeria, right from the Africa Union continental level. This organization took, in fact, from the West and Central African commitment that we have been harping on since we came in here, to the African Union continental strategy on education for health and well-being. These agencies carried along Federal Ministry of Education and Health to Ethiopia, to Addis in Ethiopia, to sign that continental strategy. Okay, and even after the WCA commitment was signed, the these same UN agencies brought us together sometime last year, around July or so, in Nasarawa State, and we developed that plan. Everything, the WCA strategic plan, everything we have done so far has been in unison, unlike before. Even the efforts to review the school health policy is being done in unison. Okay. Um, as we speak, there is ongoing effort to generate data in what we call global school health survey and global school health policies and practices survey. It's a huge, massive project. Okay, and these same agencies brought the Federal Ministries of Health and Education together. And whatever we are doing, we are also looking ahead and thinking of how it's going to percolate and trickle down to the subnational level. So, as I speak, we are impact on the health of adolescents and young people. Issues like smoking, injury prevention, issues like even the HIV and AIDS, alcohol intake, and all that. Then, for the global policies and practices survey, we are looking at the leadership in schools. We are looking at food and nutrition services in schools, the health education, which of course will not exclude HIV and AIDS, physical education, issues of safety, okay, among the school environment generally, how hurtful or otherwise it is. It is this body of evidence or data that will help us to know whether or not we are making progress and which areas we should deem we should refocus our efforts. So in all of this work, it has not been business as usual. It has not been health alone or education alone. We have always moved together.
Very
Thank
much.
you for now.
Thank you very much, sir. We are glad that we are moving together. Let me ask Dr. Shumekun, what is UNFPA doing differently in terms of training and support for income generating activities for adolescent girls and young women? Because most of these adolescents still do not have the right information concerning SRH, family planning, EMTCT, and condom use. What is UNFPA doing differently in terms of training and supporting them for income generating activities? Yes.
Thank you very much. For UNFPA, we have various projects, one of which we call the STEM. The STEM is one which we have like an academy where girls are taken through, girls who are vulnerable, including persons with disability, those living with HIV, are taken through an academy where they learn about sexual reproductive health. They also learn about soft skills. So soft skills about how to make bed sheets, how to make reusable pads, how to even make handbags. They're taught how to make handbags, school bags that they can sell to their community. And one other thing which we do is that beyond just learning, we actually connect them. So there's a connect to off-takers. So when there are shows or there are trade fairs, they're actually connected to those trade fairs. So and connected to various off-takers who pick their products. And for us, sometimes when we even have programs as UNFPA, we actually ask them to make. So it's not just that we're empowering them, but we are equally also getting their products and also showcasing it. And this we do not only in the development setting, we also do in the humanitarian setting. One other thing which we've begun to do is to digitalization. So we know that there's this gender divide when we're talking about the innovation and also in digitalization. So many of our girls their capacity are built so on digital literacy. Many of them also, particularly those the IDPs, the girls in the north, those who could not even use emails now know how to use emails. They now know how to can do a resume for other girls or for other people in the community and get paid for it. They also know how to use Excel to analyze just basic data. And in the cohort, for example, that we've done in the humanitarian setting, we have like about 200-300 IDP young girls. And one other layer we add to it is that we also bring them even into government settings. So they serve as like interns or office assistants where they can also use these skills to earn. And we equally bring them also to international fora or to conferences like this where they're able to tell their story, talk about how their lives have transformed and how they are also able to impact other girls with the skills that they've learned. And that way we know that they're less vulnerable, because once a girl is empowered, she's informed, she can take decision about her body, about herself, and she would definitely be able to impact her community. Thank you.
Thank you very much. Thank you very much. We are rounding out. I only have two questions here. And this is an appeal. I think this goes to the madam from the OT program. Please, as you scale up in the states, could you please include Delta states if somebody is appealing to you? All right. Okay. Dr. Babatunde, I would like you to respond to this. Please, can you throw more light to the involvement or comment or commitment of Nigerians towards WCA? Can you throw more light to the involvement or commitment of Nigerians towards the WCA commitment?
Yes, thank you. Thank you so much. Just like what the ambassador has said, tomorrow we are starting an advocacy campaign through the social media platforms and various communication channels. We've done this in 2 series, and throughout those two series, we're able to reach more than 7 million adolescents and young people across Nigeria about the WCA commitment. It is clear if an adolescent is young person, he will not be educated, or he will not be educated. If the person is not educated, he will not be healthy. And if they are neither educated or healthy, then they will not try. So we're saying we need to have massive mobilization and advocacy, awareness, sensitization across all our different networks. And we are glad that some of you have signified your address and all this. We want you to come and join this train that will build the momentum for us to show clearly that it's important that adolescents and young people are put in the front burner. When you give them the right information, then they'll be able to do the right things. And when you demand, and government, Ministry of Health, Education, they are committed to this, then you will follow up to ensure that this is done so that we can live a healthy and productive life. We want everybody to be involved, parents, traditional rulers, community leaders, those in the school, those out of school, so that all of us can develop and achieve a better Nigeria.
Thank you, sir. Sidoni, please, can I have you here? Now, the last question. When will the curriculum be implemented, and what of the young person that is out of school? when will the curriculum?
Quickly talk about that. It boils down to what we call values clarification. Everybody take the ingrained supposed values, norms, and use that to interpret whatever they are doing. So we are working together with the Federal Ministry of Education to ensure that we do a lot on those values clarification. Just like we said, the FLHE curriculum is for in school. That is a curriculum, but up till now, we do not have a national curriculum that addresses sexuality issues, family life, HIV education, or out of school. So what we are doing is to show evidence that this is working, and we have done that remarkably well in Lagos and in Kaduna. And based on that evidences and some of the data we have gathered, we are trying to see how we can now scale that up so that we can begin to address these issues in out of school. Remember, the setting is different. Unlike the in-school that is organized, out of school is not, there's no organized structure, except for maybe vocational and technical schools that we're working with, or some of the schools, people with disabilities and all those kind of things. We need to find a way and working with all relevant uh, board and technical board, vocational boards to see how we can ingrain that within their culture. So it's a work in progress. And for us to be able to do that at the last scale in Nigeria, so lot of people, how do we get to the nook and cranny? And that is why we're working with UNESCO to develop a platform where online we can train teachers and instructors. Online, students can also come in and take courses, and they can go and take get certification for that, and then they are linked to various places for referral service and uptake of information and service.
So I really want to thank our panelists. We have come to the end, but I kindly want to implore us to sit just for 5 minutes. We have some souvenir we want to share with you. But while that is going on, I will just want to ask if any of our panelists.
Actually, it's
Okay.
can we hear me? Okay, it's not really a question or okay, it's working. But I want to ask how many of us here have actually engaged young? Because I know that issues around sexuality, we are very uncomfortable about talking about it. But it's a charge for every one of us that are here that we should take it upon ourselves to when we get back, let's start engaging young people. They have SRH needs, but many of us refuse to accept that. Let's start engaging them. Let's start talking about those issues that we seem as if young people don't know about. They know about it, but they would rather have somebody sit with them and talk and provide accurate information. When you get back, it's a charge. Engage somebody, a young person in your church, in your mosque, in your neighborhood. Don't just shake your head and say that child is a bad child. Engage with that child and have that conversation. That conversation can just change the narrative and make that child or that adolescent thrive. Thank you.
Okay, thank you. Just an additional information. Sometime late last year, um, we were in Lagos to develop websites and content on comprehensive sexuality education. Okay, to make this information available to our adolescent and young people, whether they are in school or out of school. And we plan to have it in two versions. One is the app-based and the other is web-based version. Just an additional information. Thank you.
I think mine is more of, just like some fund said, mine is more of we all need to act in our own little space. Let's see what we can do to help young people. If we think that we need some form of training or all that, let's also go online, check resources and information that can improve us, and so that we're able to help young people. All hands need to be on deck. God help Nigeria and God help us all.
Yes, like I always say, we can't all take the same road, but once we have the same vision, we can all, play our little part in ensuring that young people and adolescents in Nigeria are educated, they are healthy, and they are thriving. We can start from where we are in our communities, we can start in our churches. There are a lot of adolescents and young people that are around us. And that's what I do. I don't wait till I have a crowd and say, this is the movement and we're going. So in our little spaces, we can take action, and those actions can really save lives, as the campaign is about. We can save lives of young people one at a time. Thank you.
Panelists, good evening, Mrs. Obuke, Mrs. Oye, Tomori Adeleye, Dr. Sylvanus, Dr. Sylvester, Dr. Babatunde Adelekon, Dr. Kunefun, and our own Chidima. And we really want to thank every one of you. We know it is past the normal time that we're supposed to be here, but for your commitment and your dedication to have been here, this is not taken for granted. Thank you very much. And like it was mentioned, tomorrow the campaign on Education Saves Life is going to start. Please, we are going to share this with you. As you get the message, please share it with other people. Please make sure that it is training and it is shared. God bless you and good night.